Good morning or good afternoon, wherever you are, and welcome to our webinar focusing on approved and investigational treatments for ATTR amyloidosis, both hereditary and wild type. I'm Muriel Finkel, president and co-founder of Amyloidosis Support Groups. All our previous webinars can be viewed on the webinar section of our website, amyloidosissupport.org, and on our YouTube channel. This webinar should be available and up there in a week or two. In the control room today, we have ASG's Executive Director, Paula Schmitt.
Hi, everyone.
And our Special Projects Director, Bob Gibson.
Hello, everybody.
Paula will join us later to talk about financial aid and donating unused ATTR medications. The questions sent in ahead of time will be answered first by our panel during the Q&A session after the presentations. If we don't have time for all your questions that are typed into the Q&A section, we will ask our panelists to answer them in writing, and we'll share the responses with all of you. The chat portion of our webinar has been disabled, but there will be occasional useful items popped up that are posted by Paula. Our esteemed panelists today include Dr. Rick Ruberg from Boston University, Dr. Josh Mitchell from Washington University, St. Louis.
Hello, everyone.
And Dr. Chafic Karam from the University of Pennsylvania. I'm excited to say that our three guest doctors today will be joining over 20 other amyloidologists at our ATTR meeting in Chicago on the weekend of October 24th, 25th, and 26th. We urge you to register and book your hotel soon, as the block will be filling up. The event and all the meals are at no charge, and we get an exceptional hotel rate of $139 per night, but be sure and save your pennies for the airfare. In 2023, we had 500 patients, caregivers, physicians, and firemen at this event. And with all the new treatments and research happening, it is more important than ever that we all stay informed. If you have problems with the QR code that's up on the screen, just send an email to Muriel at amyloidosissupport.org, and we'll help you register. No problems there. There will be a brief survey when this meeting is over, and we ask that you take the time to fill it out. Should you have to leave early, we will ask that you fill it out when you leave. It's important to us. It helps us develop future webinars. We'll be working off our treatment chart today, and Bob is putting it up on the screen for your reference. Paula will put a link to the chart up on the chat section as well for you. And you can feel free to email me at Muriel at amyloidosissupport.org for a copy. Okay. So now, without further ado, we will now have our first presentation from Dr. Rick Ruberg at Boston University. Dr. Ruberg, take it away.
Thank you so much, Muriel, Bob, and Paula. It's really a pleasure to be with you all today. I'm going to share my screen. So again, super pleasure to be with you all today. Thank you all for getting up early on the West Coast for joining. My name is Rick Ruberg, and I'm from the Boston University Amyloidosis Center in Boston, Massachusetts. And it's my pleasure today to lead off by talking about what's approved by the FDA to treat ATTR amyloidosis. So these are my disclosures. Every research or clinical talk that you hear is going to have some disclosures about with the companies we work with and how our work is kind of funded. So here's the overview of the presentation today that I'm going to give you. It's going to take about 10 minutes. We're going to briefly go over ATTR disease. Then we're going to talk about stabilizer therapies, which is one strategy, and silencer therapies, which is another strategy. So pretty simple. And just to remind us all that ATTR amyloidosis is a disease that actually results from a protein made by the liver that affects the heart. So the heart is kind of like the victim here. The liver makes this protein called TTR, which you can see here. Hopefully my pointer is visible to you all. And it exists in 4 identical subunits, it's called. And Dr. Maurer calls it a 4-leaf clover. Anyway, normally that clover exists as a whole protein, but sometimes it breaks apart and it begins to misfold. And then if it misfolds in a particular way, it then creates these aggregates of misfolded protein called amyloid fibrils. And I think you all know, but just to remind you, the principal clinical manifestations of amyloid are heart problems and nerve problems. And that's why today you've got 2 cardiologists and 1 neurologist talking to you about how these diseases affect the systems that we treat. And this cartoon on the inside basically shows that most of the TTR in the body is made by the liver, but there's a little bit made in the brain and the eye. And it has a couple of different ways in which it can misfold, but ultimately it causes these long, like branching, they're called branching fibrils, which you can see there. Like they look like little kind of rods that they deposit in the heart that causes the heart to become thicker, and it causes heart conduction problems. And the principal manifestation of cardiac amyloidosis is congestive heart failure. So the main point here is that amyloid from ATTR has 2 different kind of manifestations, nerve disease and heart disease. And it's also important to remember that ATTR is only one of the types of amyloid that can affect the heart. The other important type is called light chain or AL amyloidosis. We're not going to talk about that today, but in the process of diagnosing ATTR, we always exclude AL because it's more serious and it progresses more quickly. And then finally, we think of ATTR in 2 different flavors. One type is called wild type, and that means that the genetic protein, the genetic sequence that makes the protein TTR is normal. And the other type is called variant or hereditary, and that means hereditary genetic abnormalities in the protein are passed from parent to child, and those abnormalities can cause the misfolding. We actually really don't know what causes the misfolding and aggregation in wild-type amyloidosis, and that's the subject of my own research as well as many others. And so it's a great unanswered question. Why do people get amyloidosis in general, particularly wild-type? And just to remind everybody, these amyloid fibrils deposit around the heart muscle. So the heart muscle cells, which are these kind of purplish cells, are surrounded by the pink amyloid. And this is like looking at a microscopic specimen of the heart. And when that amyloid surrounds the heart cells don't work very well. That causes the heart muscle to become thicker and stiffer. It doesn't relax like it's supposed to. And that reduces the function of the heart and increases the pressure inside the heart. And that's what congestive heart failure is. And we measure that by pro-BNP or BNP in the blood. And probably all of you have had your BNP measured because that's an index of the severity of the heart failure from the amyloidosis. And that surrounding of the heart cells also causes the heart cells to get injured. And that causes some of those heart cells to die and then release another protein called troponin in the blood. So the goal of treating amyloidosis is to stop this deposition. And that's what those therapies do. The therapies that are approved don't take the amyloid away from the heart. And Dr. Mitchell will probably talk about that in investigational therapies, but they do stop it from getting worse. So this cartoon kind of summarizes the landscape of treatments. And I'm going to focus my attention on the protein synthesis blockers or silencers and the stabilizers, because this is where the approved therapies exist. And again, I'm sure you'll hear in the future, and we can certainly talk about in the Q&A, the investigative treatments that include gene editing and also removal of amyloid fibrils. So we're going to focus on the middle part here. So now let's start with stabilizers, because stabilizers were the first approved therapies. Stabilizers work basically by binding to the TTR protein and keeping it from falling apart. That's what they stabilize the protein in its native state. And the stabilizers that are approved for amyloidosis include tafamidis and acoramidis. We'll go over each one. And there's another stabilizer that existed before those 2, which is not approved, but can be used off-label for amyloidosis, and that's called diflunisal. So let's start with tafamidis. Tafamidis is marketed under the names Vyndamax or Vyndaqel by Pfizer, and it was the first drug that was approved for cardiac amyloidosis. Its indication is for ATTR cardiomyopathy or cardiac amyloidosis, and it's also actually approved for polyneuropathy, but outside of the United States. And since we're talking to an American audience, we're talking about cardiomyopathy. It's an oral therapy, so you take a pill, and the dosage is 61 milligrams or 1 pill once a day, or you take 4 20-milligram pills or 80 milligrams once a day. And that's just because the formulations are different. The trial that I'll show you used the 80-milligram dose, but the 61-milligram dose is a lot easier for patients to take. The drug is incredibly safe. It has no major side effects. It has some minor side effects. It can cause diarrhea, rarely in some people. It's been reported to cause a hypersensitivity skin rash. And more recently, we have understood that in high doses of potent, powerful statin medications like rosuvastatin that are used to lower cholesterol, there could be an interaction that causes the statin level to be higher and could cause some muscle injury. All of these are reversible when you stop the drug, however. Now, the principal kind of limitation of all the drugs I'm going to tell you is cost. And I think you're probably all aware of this. And Paula is going to talk about this in her part of the presentation. The list price for tafamidis is $268,000 a year. Now, obviously, that's a ridiculously high price. The cost to patients really varies depending upon what, the insurance coverage and the capacity for copay assistance, which really depends on the financial kind of situation of each individual patient. And some places have access to grants, et cetera. But the average out-of-pocket cost as recently as 2021 was still pretty high, about $500 per month, which is a lot, obviously. And I can tell you in my experience, most patients pay less than that, but that really varies across the United States. Now, there is likely to be a generic formulation of tafamidis in the next couple of years, which will obviously change the whole landscape, but I can't speak more about that because I don't know the details. Now, this is just this is data showing how tafamidis was proven to work. You're going to see a lot of these curves here. And I remember each one of these curves, each dot on these curves represents an individual patient. So it's really important to remember that you're looking at everybody together and not each individual person. But what you see here is that the curves separate after about 18 months. So the red line are the patients who didn't get tafamidis, and the blue line are the patients who did get tafamidis, and this is survival. And so the drug basically made people live longer after about 18 months of therapy. In fact, if you treated about 7 to 8 people, you could prevent 1 death over 30 months. And in terms of hospitalization for heart failure or cardiovascular hospitalization, you actually only needed to treat 4 people to prevent 1 hospitalization. And this part here basically shows you, these are subgroup analyses. And as long as the dots are on the left side of the tafamidis better, that means the drug was better in these different subgroups. So by support of this data, the drug was approved. And subsequent data have shown that even if you extend therapy, because that trial was only 30 months, if you extend it out to 5 years, those curves continue to separate. So this is now the 18 months, and now you go all the way out here. The patients who are on tafamidis continue to do better. And in fact, like these patients here were actually moved, this line here is moved from placebo to tafamidis, and the curves actually bent up. So even if you started patients on therapy after about 4 years, they still did better than if they were on, theoretically, if they're on no therapy alone. So the drug is very effective and it's very safe. And this is why it has been the principal treatment for cardiac amyloidosis until basically last year. And that's because last year, the drug acoramidis, also known as Attruby or Beontra worldwide, was approved. Acoramidis is also a pill. In this case, though, it's 2 pills twice a day, and it was approved in late 2024 by the company's BridgeBio that makes it. It works similarly. It binds to TTR and keeps it from misfolding. Now, similar to tafamidis, there are no major side effects. And again, like a lot of pills, it caused diarrhea in some people. And again, it was relatively low incidence, but again, stopped when therapy was discontinued. It's a little less expensive, but similarly priced to tafamidis. And similarly, the cost depends on the copay assistance. Now, there is some theoretic evidence that acoramidis is a more potent stabilizer than tafamidis. And I shouldn't say there isn't theoretic data. In vitro, so in the test tube, acoramidis is a better stabilizer than tafamidis for sure. And when you give it to patients, generally the increase in prealbumin or TTR that results from therapy is higher with acoramidis than tafamidis. And the studies reanalyzing the main study, which I'm going to show you in a second, have demonstrated that if the prealbumin goes higher or TTR goes higher, that connotes a better outcome. So there haven't been head-to-head studies between these trials, and we're going to talk about these drugs in just a second. But basically, the general concept is that it's possible that acoramidis could be better than tafamidis, but we just don't know that yet. And that's the subject of ongoing investigation. And this is a trial called ATTRibute-CM that was published in the New England Journal of Medicine that basically took 630 or so patients, randomized them to the drug, and followed them for 30 months. And I think I'll get away a little bit about the details because it's not really that important. Though you should know that most of the patients who are on this trial were wild type patients, which is true for most of the trials. And here the curves are kind of reversed in terms of they're kind of presented upside down. But the general concept here is, in this case, the blue is the placebo and the acoramidis is the orange here. And this is also demonstrating improvement in survival, because this is lower than this. And the curves separate just like similarly after about 18 months or so. And again, like I said, the dots are on this side, the acoramidis better, indicating that in the subgroups, the drug was better. And here you can see the number needed to treat to prevent an all-cause mortality or first hospitalization was 7, and hospitalization annually for cardiovascular disease was 5. Kind of similar to what tafamidis showed, but the placebo group was different. We can talk about that in the Q&A, but by and large, relatively similar sort of outcomes with a different placebo group. And so on the virtue of this data, the drug was approved in 2024. And the drug is also going to be used in a new exciting trial called ACT Early, which I can talk about in the Q&A. And this is basically the idea, if somebody is at risk for TTR amyloidosis, so they've acquired a pathogenic gene like T80A or V142I, if you treat them with acoramidis, can you prevent them from developing amyloidosis? This is never been a trial like this before, and that's what this drug is going to be used as, and the trial's already opened. It's enrolled about, I think, 80 or so people, maybe 60 people. Can't remember the exact number, but it's going to be testing this very question. Can you prevent amyloidosis from developing in people at risk? And just to remind everybody, diflunisal was the drug that was first used for amyloidosis, because back in 2013, John Burke from my institution demonstrated that it worked in ATTR polyneuropathy. And my group has basically shown in subsequent retrospective studies, like looking back at the past, not prospective placebo-controlled trials, never been done with cardiomyopathy, that the drug definitely appears to help people live longer and also makes their heart function better. But we don't really use diflunisal now except for people who are risk carriers, like ACT Early is going to be for acoramidis, or other scenarios where they can't get the other drugs because they don't have cardiomyopathy or polyneuropathy. So changing gears now to the silencing medication. So these drugs basically work to stop the liver from making TTR. And the principal drugs are seen here. We're going to talk about vutrisiran primarily, and then we'll talk a little bit about eplontersen. And then the other two are almost more historical, although patisiran is still used. So vutrisiran, or Amvuttra, is marketed by and developed by Alnylam Pharmaceuticals. And this drug has approval for both polyneuropathy and cardiomyopathy in the United States, which is unusual because the stabilizer drugs are approved for cardiomyopathy in the United States. So the drug is a subcutaneous injection. So it's not a pill. It's an administered subcutaneous medication that's given by a healthcare provider, a nurse or a doctor. You can see the dose there. And it was approved in 2022 for polyneuropathy and just earlier this year for cardiomyopathy. Now, because these drugs knock down TTR, which is a principal transport protein for vitamin A, patients who get these drugs are at risk for developing vitamin A deficiency, so you have to take extra vitamin A when you're on these drugs. The side effects are arthralgias and injection site reaction, again, relatively low frequency. It's more expensive than tafamidis or acoramidis at $475K per year, and similarly, it has the same kind of variation in terms of cost to patients. Most patients who are on these drugs that I've treated generally get the drug covered by their insurance with very acceptable copay. But again, experience varies. These drugs don't raise TTR, they lower it. So in this case, they knock down production of TTR by about 80%. And I'm not going to talk about the Helios A trial because I'm sure Dr. Karam will talk about that. That's the trial that demonstrated its efficacy in polyneuropathy. But in the Helios B trial, the efficacy in cardiomyopathy was demonstrated. And this trial was published again last year. And again, you're now experts and you've seen these curves. So the orange curve here is better than the blue curve because fewer people had basically, in this case, died. And so again, it showed the drug was effective. And again, all the dots are on the vutrisiran better side. Same thing here in the subgroup. And this is the monotherapy group. We'll get into this in the Q&A, I'm sure, but the placebo patients in these trials, a proportion of them were actually taking tafamidis because you couldn't not give people a drug in some cases. And so, but this is the analysis only from vutrisiran, and again, shows sufficient, consistent benefit to drug alone. So by virtue of these data, vutrisiran is approved for cardiomyopathy in the United States. And we know subsequently that, again, you extend the study out further, just like in tafamidis and acoramidis, the curves continue to divert, meaning that the vutrisiran patients, they do get a little bit worse over time. As you can see, there's still some outcomes. In this case, this is again the cumulative incidence of a combined endpoint, but the placebo patients do much worse. And similarly, these are the relative reductions compared to placebo, pretty significant reductions. So the drug definitively works, and is an option. And kind of last in terms of that's coming into the game is eplontersen. And I say last because from cardiomyopathy, the trial is still ongoing. Eplontersen, or Wainua, marketed by and developed by AstraZeneca, is approved in the United States for polyneuropathy, and it's not yet approved for cardiomyopathy. It's also a subcutaneous injection, and it's given every 4 weeks instead of every 3 months. Likewise, it needs vitamin A supplementation because of the transport protein knockdown. Similar sort of side effects, although we really don't know what the side effects are going to be in a large study of heart patients. And it's also similarly quite expensive. Actually, wholesale price actually a little bit more expensive than polyneuropathy. Than vutrisiran at present. Now, the difference between vutrisiran and eplontersen is that this can be self-injected. So just like the GLP-1 agonists like Wegovy or Ozempic, or the PCSK9 inhibitors like Repatha, patients can give this to themselves, which is a lot easier. Now, that also means that the coverage in Medicare is different. We can talk about that in the Q&A. And the data that demonstrated its efficacy that got it approved for polyneuropathy is the NeuroTransform trial, and the Cardio-Transform trial is currently fully enrolled. And the biggest cardiomyopathy trial in amyloidosis ever to be published, ever done, 1,400 patients. And the results hopefully will come out sometime next year. Now, I just mentioned historically patisiran, which was the first RNAi silencer that was developed by Alnylam that was approved. This is an intravenous injection that's given every 3 weeks. Because of the intravenous injection, it requires pre-medication and can be challenging for patients. They have to come in to a facility every 3 weeks for treatment, and some of you are probably on that. Also needs vitamin A supplementation. It's just a harder medicine to take for people because there's a lot more reactions associated with it, which is why you get all these pre-medications. And obviously you have to come in as opposed to doing it at home. And the efficacy for this was in the neuropathy was Apollo A, and the Apollo B trial in cardiomyopathy was a 12-month trial. It wasn't powered to look at adverse endpoints like survival and hospitalization, but it did look at changes in things like BNP and troponin level. But basically, even though the FDA advisory committee voted to approve it, FDA declined to approve it back in 2023. So patisiran is only approved for polyneuropathy and not cardiomyopathy. And this is my last slide, and I'm sorry I went a few minutes over, but there's a lot of unanswered questions in treatment, which we can get into the Q&A. First, like as I discussed, what is the best strategy to start with? Do you start with which of the 3 drugs? We don't really know, and we can talk about that. Which one is more cost effective? How do we know if a drug's not working? How do we monitor people in a kind of systematic way? And then if it isn't working, what do we do next? We don't know that either. Is there any benefit to putting the 2 classes together? Do you put someone on acoramidis and vutrisiran, or tafamidis and vutrisiran? We don't know. And finally, are there certain people who should be treated differently? Like if you're a variant carrier versus a wild type patient, or you're at different stages of disease, should you get a different therapy as your initial treatment? So I know that was a lot of information, and I thank you for the little extra time, and I look forward to answering your questions in the Q&A. And again, I really appreciate the opportunity to speak with you all today.
Thank you so much, Dr. Ruberg. That was really great. And a reminder that the video will be up on our YouTube channel and our website in 2 weeks or so. So you'll get to hear it again if you didn't hear it all. So don't worry about that. And next we have from Washington University in St. Louis, Dr. Josh Mitchell, who's going to talk about investigational treatments. So Dr. Mitchell, take it away.
Hello, everyone. Fantastic presentation from Dr. Ruberg. Thanks so much. So I'll kind of take it to the next level, which is, where are we going from here? So as Dr. Ruberg had some disclosures, I'll note that I participate in clinical trials as he does. I also serve as a consultant and advisor to many of the amyloid companies to help try and continue to improve patient management. So if we go back to this image, which Dr. Ruberg also used, we can see the overall cause of how the initial transthyretin polymer eventually results in amyloid. And we have treatments that attack this at different places that are currently available. We have those stabilizers, as he discussed, and the silencers. And so what we'll talk about is where do we go from here? Many of the treatments, as he mentioned, are mainly designed at stabilizing what has already happened. And as they stabilize what has already happened, they don't necessarily reverse disease. And so there's interest in how do we reverse disease. And there's also interest in how do we do an even better job of stabilizing the protein. And there's certainly a chance that if we stabilize everything or silence it, we get rid of the amyloid fibrils enough that the body is able to heal to some extent. And although our overall expectation on current treatment is that people don't necessarily get better on that treatment, we do see some people that do get better. And so trying to understand the differences among people is also an area of interest. I'll start off, though, with just backing up a little bit and looking at future trials and stabilizers. And Dr. Ruberg already mentioned this to some extent with the ACT Early trial. So I will briefly discuss that one since he already brought that up, and then go over some other future and ongoing trials. So the ACT Early trial is really a huge sea change. It's been awesome to see all of the improvements we've had in amyloid treatment over the last several years. As many of you know, there was no treatment for TTR cardiac amyloid FDA approved in the US before 2019. So to now have 3 approved treatments is amazing. But as many of you know, we don't have treatment until you actually develop heart or nerve involvement. And many people may have signs of amyloid deposits on a carpal tunnel biopsy, or there may be concerns even on a lumbar biopsy if they have spinal stenosis, or they may have the gene and know that they may expect to have amyloid at some point in the future. So a big question is, how do we prevent that? And that's exactly what the ACT Early trial is designed for. Specifically, it's looking at patients who have hereditary gene variants. These gene variants put them at risk for developing amyloid, but they don't yet have heart or nerve involvement. And so the trial is enrolling patients within 10 years of what we'd expect their onset to be. If they have family members, we adjust the expected onset based on those family members because there are variations across different populations. But if we don't know for sure, we have tables that help us. And so if you have V122I mutation, which is the most common mutation in the US, we expect that disease onset at 70 years of age. And so you can enroll in the trial at 60 years of age or later. Again, that's modified somewhat based on the family history. V30M, the most common mutation in the world, has 2 different onsets, one really early, one later at 60, and so depending on that, it affects your enrollment. Patients will be randomized to acoramidis or placebo, and then undergo regular heart and nerve evaluations throughout the study to see when disease starts. If disease starts, they're automatically switched if they're on placebo to acoramidis, or they're continuing on acoramidis and then followed over time. So really a powerful study that can now hopefully help us start to prevent disease. Moving on, this now focuses again, the rest of the trials will focus on patients who already have heart involvement. And so we have known silencers. We have vutrisiran, which is approved for the heart. We have eplontersen, which is being studied, as Dr. Ruberg mentioned, with CardioTransform. We also have ongoing trials or upcoming trials with both CRISPR-Cas9 or other versions of these silencers. So we'll talk about those next. So CRISPR-Cas9 is a really fascinating technology, and it seems futuristic, but it's actually been studied now for over 10 years, and we've had hundreds of patients successfully get this treatment. But the treatment uses the Cas9 mRNA and CRISPR technology to essentially target the protein in the liver, edit the gene responsible very specifically. So a lot of studies went into saying, let's make sure we're targeting the TTR gene specifically. Let's turn off the TTR gene specifically and not affect other parts. And through this technology, the molecule targets the liver, it unwinds the DNA, it specifically cleaves out the gene that causes, that produces TTR protein. And so through this, it reduces TTR production by 80 to 90%, just like a silencer. But instead of a silencer where you're taking it every month like eplontersen or every 3 months like vutrisiran, it's a one-time treatment that potentially is lifetime. It's been studied up to 3 years with continued improvements. So looking at those results, we can see here on the left side of your screen, the percent change in transthyretin. So at the start of the study, this was from the phase 1 study. Right now, the phase 3 is ongoing. So to back up for a quick second, whenever a new medicine comes to market, it first starts out at phase 1, which is somewhat testing efficacy, but also testing safety. and is in a smaller population, but before it comes to market, we do a phase 3 trial in a larger population. So in these initial patients, we see that the transthyretin protein is significantly reduced to about 90% lower, and that's maintained on this slide through 24 months. The company is going to update these soon to show that that continues through 3 years, and we really do expect it to be lifelong from that one treatment. And then on the right side, just a slightly different way to measure the same thing, just with absolute levels. And then the actual effect on the patient. So it's one thing to look at the transthyretin protein. It's another to see what the actual effect is for the patient. And we see that the NT-proBNP that Dr. Ruberg mentioned is a way for us to measure heart failure. And we'll talk some more about heart failure later in the symptoms discussion. But that's very stable over 1 year in this particular slide. Cardiac troponin T, very stable, might even be slightly decreasing at the end, but basically stable. The symptom score shows even improvement, and then the 6-minute walk distance is stable. So we see a great effect on outcomes, and the thought or hope of the company is if we can completely shut down production of transthyretin, can patients' bodies actually start to improve over time? We don't know that, but we certainly are hoping for as much stability as possible. Adverse effects are always important to note. There's about 14% infusion-related reactions. What this means is some patients may have a lower blood pressure, or they may feel a little off during the infusion. On average, it's been about 1% for patients that have been admitted for observation in the hospital after their infusion. And then there can be a mild liver enzyme increase, but these are generally all temporary. So far, it's been found to be very safe, with a small proportion of patients having to be admitted for overnight observation, but all of those patients recover. So a lot of hope in this. We still have traditional silencers being tested as well. So nucresiran is like a vutrisiran injection, but instead of every 3 months, it will be given every 6 months. And we have evidence that this has a prolonged effect. This will be given on add-on therapy. And so both the CRISPR-Cas9 trial and the nucresiran trial, you can already be on a stabilizer, so you can be on tafamidis or acoramidis. However, you wouldn't be on a silencer. Certainly there's no reason to get the CRISPR-Cas9 treatment on top of a silencer therapy. And so patients on stabilizers can be on the trial, but not on silencers. And so this will also essentially test in the US whether nucresiran helps as add-on therapy, although worldwide we will have patients who are not on baseline stabilizer therapy. Next is a really promising area as well, and these are antibodies that target the amyloid in the body. And as an antibody targets the amyloid, the body can then remove the amyloid from the body. So here we have hope that we actually improve the disease. And so this is an image from an upcoming trial from Novo Nordisk that bought Prothena, and the antibody targets the circulating amyloid, both in the blood as well as amyloid that is deposited in organs in the body, such as the heart. Here is a depiction of the amyloid, and here we see the antibody binding to the amyloid. And then here on the bottom right, we see a macrophage, which is the body's own type of cell that helps clean house. And it can start to now, once the antibody binds the amyloid, it can recognize the amyloid and help clear it from the body. And in the Alexion trial that is ongoing but is closed to enrollment, we had some fantastic images, and it's felt that the upcoming antibody will be very similar, where we see improvement in imaging of amyloid over time with the depleter. And so here on the left side of your screen, you see patients at baseline, and then the higher uptake in the heart is from the amyloid itself, and that improves over time with that depletion agent. And so this phase 3 trial is very promising, but we don't have results yet. So far, patients are doing very well on the trial and seem to be responding to the antibody, and there is a lot of promise. The newer Prothena antibody, so this particular study from this particular company is closed to enrollment, but the new antibody from Novo Nordisk will start enrollment late this year or early next year. They're just sending out the initial information to sites, and sites are working on getting up and running soon. In a related study, we have the REVEAL study, and this is not a treatment study, but it's using the similar technology in being able to better detect amyloid in the body. And so our current scanning technology, the pyrophosphate scan, the PYP scan, it uses a tracer that actually binds to microcalcifications in the amyloid. So even though it is really helpful in finding amyloid in the body, it's not as specific as you would want it to be. And so this particular tracer is more specific in binding amyloid and can bind to different types of amyloid. And so we're hopeful that this will help us improve diagnosis in patients with both transthyretin amyloid as well as other types of amyloid. And that study is also ongoing for patients who don't yet have a diagnosis of amyloid, but we're trying to evaluate them for amyloid. So if we review some of the ongoing or upcoming trials, we have the depleter trial, which is from Alexion AstraZeneca. That has completed enrollment. Many of these trials require a certain threshold of NT-proBNP for enrollment. So the NT-proBNP goes up as your heart gets a little sicker, a little stiffer, or you have extra fluid. And they're using this cutoff just to make sure that people really actually have heart disease and that they're appropriate for the trial. And so depleter trial used a cutoff of 2,000. The Novo Nordisk trial will only use a cutoff of 1,000, although some of their patients they're going to make sure have at least 2,000 as well. So there'll be a mix, but at least to start off, the cutoff is only 1,000. And again, we expect enrollment late this year, early next year. The CRISPR-Cas9 trial has ongoing enrollment. The NT-pro cutoff is only 600 for that, so it has a lower threshold to be enrolled. The nucresiran trial will have the lowest with an NT-pro BNP of 300. I'm not sure if it started at other sites. Our site at WashU will start in the very near future. And then the REVEAL study is ongoing. The other thing I'll at least mention is there's some other inclusion/exclusion criteria for these trials. You can't have had a malignancy often in these for the last few years. They want some level of functionality. You can't, unfortunately, be wheelchair bound. And so if you're interested, certainly seek out a trial center and discuss with your physicians if you're a candidate or not. Thoughts for the future is how do all these play in together? What will our regimen be over time? Will we, for instance, use stabilizers and silencers early on, but if a patient starts to advance with their amyloid, will we then use a depleter to get them back to a baseline and then transition back to a stabilizer silencer? Those are ongoing questions. It's an ongoing question, even though the depleter trial is really set up to go over the course of a couple of years. We don't know whether in the future you'll just get a few treatments, maybe 6 months treatment is enough to get you back to a baseline and then go from there. Those are ongoing questions that we won't have the answers to right away, but we'll continue to explore moving forward. So with that, I'll pause and we're going to hold questions to the end, but I look forward to the Q&A section.
Thank you so much. That's the first time I saw the name of the Novo Nordisk trial, Cleopatra. We're not going to forget that one, are we? Okay. And thank you so much. And a reminder, folks, that the presentations will be up on our YouTube channel and our website in a couple of weeks. And next we will hear from the #1 world neurologist and in amyloidosis, and that would be Dr. Chafic Karam. So Dr. Karam, take it away.
Thank you very much, Muriel, and thank you everybody who is here today. So, we have a lot to cover here. I'm going to try to cover first is symptoms management because a lot of the treatment have been discussed already. And you have to remember, this is the same disease, right? Amyloid that affects the heart, amyloid that affects the nerve. The treatment is going to work on both. So a lot of people are concerned, oh, am I on this one or this one? The good news is that treatment will target amyloid everywhere in the body. So I'll start with the management, and if I have time, I will talk about the treatment as well. We'll first start with the sensory symptoms, which can really affect the quality of life of our patient and the dysautonomia. And then we'll talk about the disease-specific treatment that can modify the natural history of the disease. Okay, so as you know, this is amyloidosis. It's circulating in the body. It's being secreted by the liver mainly, but also by other organs. It's going to deposit everywhere. It's going to deposit in their carpal tunnel syndrome and your nerves going to the heart and the guts. It's going to drive it to the nerve that's going to your feet and your hands, in your GI tract, in the heart, in the eyes, and even in the brain, depending on the variant that you have. But the good news is that the treatment really will target many of these organs. What are the symptoms that patients present with the neuropathy? You're going to have sensory symptoms. We talk about pain, stabbing, shocks, burning sensation, altered sensation, numbness, tingling. They cannot feel the temperature very well. They have a tingling and pringling, and obviously the balance can be affected as the disease progresses. The motor part of the nerve, and you have to remember the nerve is made of motor and sensory. It's going to cause weakness as the disease progresses, tripping, foot drop, walking difficulties, and weakness with the hands, difficulty opening jars, holding a pen, and loss of dexterity, and so forth. And then for the autonomic nervous system, this is everything that you don't think about, but your body does automatically, like your digestion and your bowel bladder. Man will have erectile dysfunction, lightheadedness. When they stand up, you feel lightheaded, like you're about to faint. And if it's severe enough, you may faint. Sometimes you may just feel confused, incontinence, GI manifestation. People feel full early, or sometimes they have diarrhea every time they ate. And then sometimes they have to get up to the bathroom several times during the night, which is obviously very annoying. And then they lose weight because of that. Loss of hair, sweating abnormalities, heat intolerance, especially right now, it's very hot in Philadelphia. Blurred vision, dry eyes, and dry mouth. So, as we mentioned before, we're going to target the symptoms, which will hopefully improve the quality of life of the patients. And then we're going to try to target the TTR to stop the progression of the disease, hopefully, and perhaps sometimes reverse some of the damage that has been done. So let's talk a little bit about the pain. This is an annoying thing. It dramatically affects quality of life. A lot of our patients suffer from it. And the bad news is that we don't really have any very specific treatment for pain and amyloidosis. But the good news is that we do have drugs that we borrow from other conditions that can help lessen the pain and helps it. The other thing about pain to understand, it's complicated. You know, the brain plays a central role, your spinal cord, and chronic pain can by itself cause more chronic pain. So we have to try to target it early on before things get a little bit out of control. And the way we target the pain is that we can use topical things like local anesthetics. Sometimes we prescribe a topical cream, lidocaine, and so forth. And then sometimes we do use other drugs that can target the brain or the spinal cord itself, like antidepressive drugs. And obviously, opioids is another way to target the brain, but we try to avoid it because long-term complications are many, and some of them can be deadly. So we only use them in cases where the pain is refractory. So what are the medications that we typically use? They're anti-seizure drugs such as pregabalin, gabapentin. These are the ones that we use the most, but there's many other like Topamax, carbamazepine, and so forth, oxcarbazepine, mexilidine, and so forth. Antidepressant, duloxetine, venlafaxine, nortriptyline. These are some of the many other medications that can also work on pain. So anti-seizure drug and antidepressant both can help with the pain, with the tingling. One thing that we cannot address at all is the numbness, the dead asleep feeling. Unfortunately, we cannot suppress that. We can suppress the tingling, the burning, the shooting pain, the electrical pain, but the numbness, which can be very annoying, we don't currently have anything for that, unfortunately. And as we mentioned, topical drugs can sometimes be helpful. And then in very advanced cases or refractory cases, you may do opiates, and sometimes people get spinal cord stimulator, and so forth. Now, the issue with these drugs, they all have complications, okay? None of the drugs that we take doesn't have any side effects. So when we're discussing different medication, we have to take into consideration is the patient having severe constipation. Then probably a tricyclic like nortriptyline or amitriptyline is not going to be a good idea. Or if they have orthostatic hypotension, we don't want to do that. The gabapentinoids can make people feel sedated, dizzy, they can weight gain, blurred vision, water retention. We just had a question now about potentially long-term damage with dementia, and I'm happy to discuss this a little bit later. And then the opiates can cause constipation, they can cause sedation, and obviously they are addictive drug, and we're trying to reduce the number of medication that the people are on. And then alternative treatment should not be forgotten, because sometimes these can be very helpful. People sometimes soak their feet at night, and that is helpful. They take alpha-lipoic acid, which is a supplement, can help. Exercise obviously can help. You know, I have a lot of patients who really like the local ointments with the cannabis derivatives, etc. Acupuncture can sometimes help, and so forth. Okay, now let's talk about dysautonomia. This is a major other factor, and I'm going to include here the GI manifestation because sometimes it's hard to tell which is which. But basically, the autonomic nervous system is what controls everything that you don't think about. You know, how much your pupils need to be dilated, how fast your heart needs to beat, how dilated your airways need to go, the secretion from the liver, the blood vessels should be dilated, should they be constricted, your digestion, moving the food around and absorbing the food, and eventually going to the bathroom and so forth. So all of these are controlled by something called the autonomic nervous system, which is located both in the brain, spinal cord, and in the column next to the spinal cord. And what are the symptoms of dysautonomia? Orthostatic hypotension. People stand up, they don't feel well when they stand up. They feel confused. They feel that their vision is dim. They feel tired, fatigue, headache, especially pain around their shoulder. And if its symptoms are bad, they may unfortunately pass out and injure themselves. So it can be very serious. Erectile dysfunction in men, it's a major issue. Difficult to treat. Heat intolerance, because you don't sweat very well. Your body overheats very quickly. And I have some patients who come tell me, no, doctor, I sweat a lot, actually. I'm sweating more than usual. Well, the issue is that, yes, you're sweating in your torso because you're trying to compensate for the lack of sweat in your legs and in your hands because there's neuropathy there. And that's why you think that you're sweating more, but you're actually not. The GI issues can be very problematic. We talked a little bit about those, early satiety, the food not moving around very quickly, or on the opposite, moving very quickly. And sometimes you have both, alternating diarrhea and constipation. And obviously, bladder incontinence. You cannot hold your pee, or you have issues emptying your bladder. That can be another problem. The orthostatic blood pressure is a major issue and sometimes can be challenging to treat, especially once people have heart failure, because typically what we need to do is tell people take a lot of salt and water. And obviously, if you have heart failure, your cardiologist is going to tell you not to do those. So we have to kind of avoid those. Abdominal binders can help because they can move the blood flow from the GI tract up to your brain where you need it the most, so you don't pass out. Another thing, if things don't work very well, we can prescribe medications such as midodrine, droxidopa. These are specifically for hypotension. They also have their own side effects, but there's also other drugs like pyridostigmine, which can help a little bit with the blood pressure, also with the constipation and fatigue and so forth. And then atomoxetine and fludrocortisone, which retains salt and water. So we have to be careful. We have to discuss with your doctor which one is best for your situation. But obviously, you need to know that there are things that can help. GI issues, if the major issue is constipation, then we have fiber supplements, pyridostigmine, metamucil. Senna, if people have diarrhea, then loperamide, Lometil, tincture of opium. Obviously, there's also your change in your diet sometimes can be very helpful. Actually, that's one of the most helpful things. For gastroparesis, we have Reglan, which is also called metoclopramide, pyridostigmine, or mestinon, erythromycin, which is an antibiotic, can help with that as well. If you have nausea and vomiting, on the Centron, and people who needs appetite stimulant, mirtazapine is also an antidepressant, so can help with sleep, etc., and can also help with depression and increase the appetite for people who are suffering from that. For the incontinence, again, you have to discuss with your doctors because these drugs can all make other symptoms of amyloidosis worse, but anticholinergic, like oxytrol or dritropan, and these can help with the with the bladder issue. Sorry. For the erectile dysfunction, sildenafil is one of the short-acting, so I usually prefer that just because if we are going to have side effects, then we would know and it would go away after a few hours. Okay, I think I have a little bit of time to talk about other things and then the treatment specifically. Dry eyes, we use artificial tears, hand weakness, occupational therapy. If people need carpal tunnel surgery, then we send them to the hand surgeon. Obviously, in the beginning, you can wear a little bit of wrist splints, see if that helps. But a lot of time, unfortunately, you do need a surgical evaluation. If people have foot drop, we recommend AFOs, walker if they're having more balance issues. We don't want to fall because fall will get us into trouble. You may break your wrist or your hip, and we don't want to do that. And then another thing that we see a lot of in our patient with amyloid are the neck and back issues. And sometimes these can be caused just by normal aging and gravity and arthritis, but sometimes there's also amyloid deposition in the ligament in the spine, and that makes the space tighter. So we may have to refer them to exercise, PT, and spine center where they may need an injection or even surgery if things are severe enough. Okay, I think I have a few minutes for disease-modifying therapies. Muriel, please stop me if I'm taking too long. But the disease-modifying therapy are going to target the TTR. As you heard before, there's different type of amyloidosis, so not all of them are going to be targeted. So if somebody has AL amyloid, they're going to need to target the plasma clone cells with chemotherapy. If they have Chilzolin or amyloid ApoA1, they're not going to be targeted by the TTR. But the TTR is the most common, comes in two flavors. You have the genetic form and you have the acquired form where you don't have a genetic mutation, but you still have amyloidosis, unfortunately. And as we said, the current treatment really target the liver or the circulating TTR. So if you have amyloid that's being deposited in the brain and in the eye, we don't have anything approved yet, but we do have things that are promising and hopefully in the future they'll become available. The other thing that's important to know about this variant, about TTR, is that depending on the variant that you carry, your symptoms are going to be very different. So you may see, in the Amyloid Support Group in October, if you go there in person, you may meet somebody who doesn't have neuropathy at all and somebody who has really severe neuropathy and no cardiac involvement at all. So depending on the variant that you have, your symptoms are going to be very different. Okay, so what is approved right now by the FDA and available in the United States? You have Onpattro, which is patisiran, and it's an infusion every 3 weeks. You have vutrisiran, which is amvutran, that's an injection under the skin every 3 months. And then you have Wainua, which is eplontersen, and that is an injection every month. So all of these drugs are very effective for polyneuropathy. We also think that they work on the heart failure as well. And actually, Amvuttra is also approved for cardiac ATTR, whether it's wild type or hereditary TTR. So this is a very important thing. But again, I reassure my patient that these drugs do exactly the same thing. So I think all of those should work on the heart as well, and on the GI and dysautonomia, etc. And these drugs that are not approved for the neuropathy, but they are available. Tafamidis, acoramidis for the cardiomyopathy, and diflunisal is an off-label drug. All of those will also work on the neuropathy, but we don't know if they're better than those or not. So I usually prefer those if I have a patient with neuropathy. And then in the future, we'll have other therapies. We've discussed those in the prior talks, but tolcapone is something that I'm interested in because it can potentially penetrate the eye and the brain. So if somebody has manifestation, obviously there's no study yet that shows that, but hopefully in the future there'll be a trial to get it approved. Okay, patisiran and inotersen in 2018 changed really how we treat people with amyloidosis. These drugs are so effective compared to anything else we had in the past that they are really, I would consider them a revolution. And people, that I've seen before these treatment became available and after these treatment became available, it's dramatic. I mean, it's really sad for people, unfortunately, before the availability of these drugs. They had a horrible, horrible disease, but now things have thankfully dramatically changed and improved. These are the trials. I'm not going to go into a lot of details, but what they do, they diminish the TTR production by the liver. So they go to the liver and they tell the liver to stop making this TTR protein, which, by the way, you may check it in your lab. It's called prealbumin in most labs, prealbumin. And once you start the drug, you're going to measure your prealbumin before and after, and you're going to see that it dropped dramatically. Now, the only warning thing is that if you are on a stabilizer, meaning that if you're on tafamidis or acoramidis, it may not drop as well, because tafamidis and acoramidis, what they do, they actually stabilize the protein, so it increases concentration in the blood. But if you're not on any of those, then you'll see that it drops dramatically. And the other thing is that the neuropathy improved with these medications. Not only it stabilized, this is the blue is the people who were on patisiran, for example, and this is the placebo. You see how they keep worsening and really fast, by the way. It's a fastly progressive neuropathy. But those on patisiran not only are stable, but they also improved a little bit. Same thing for the quality of life. Things are a little bit different with the inotersen group, where they more slow down the disease. Inotersen is no longer available for use because it caused a lot of, not a lot, but it did cause thrombocytopenia. So there was a black box warning, and we tried to, people had to get blood tests every week if they were on it. So now it's no longer available, and it's off thing. The other thing that is very reassuring to me is that the companies are looking at long-term data. And you may think that, hey, does this drug lose benefit over time? And it doesn't look like that, because the TTR suppression continues for many months and years after you start people on treatment, which is really a great thing. And not only that, looking at 5 years outcome, you can see how the neuropathy is really stable. This is after 5 years, which is something really that we don't see before these treatment became available. However, the people who were on placebo, unfortunately, lost some, and they became stable once they started treatment. This is the line that shows you that when they started treatment. However, what is lost is lost. They never rejoined the people who were initially treated earlier on. And that is why we are obsessed in starting treatment and finding people as early as possible, especially when you have a family member. This should be very easy and they test positive. We should really be able to start treatment as soon as the disease start. The other thing is that this is with patisiran, and you can see also affecting the survival. So significantly affecting survival, people who are on the drug compared to placebo and compared to people who started the drug late. So that shows you that, yes, the patisiran was not approved for heart failure and cardiac ATTR amyloidosis, but it still worked. So these drugs will work on the neuropathy and the cardiomyopathy and other organs as well. People also gained weight, by the way. Now, the good news is that we have version 2. So patisiran and inotersen both have improved version. One, inotersen, you do it once a month under the skin on your own. And then vutrisiran, you do it once every 3 months with a healthcare provider, also under the skin. And these drugs are equivalent to the old patisiran and inotersen. So we don't have major reason to think that these are less effective than patisiran, for example. Okay, again, showing you that they stabilize things pretty nicely. So in summary, the TTR neuropathy, we should focus not only on treating the disease and altering with vutrisiran or eplontersen, but also on trying to relieve some of the symptoms that come with the neuropathy. And as I showed you, we have many different options. And unfortunately, a lot of time it's trial and error to see what works best for which patient. And it also depends on what other organs are affected. Now, we have to be realistic. We cannot, for example, completely reverse things. So some nerve damage and dysautonomia are going to be chronic and irreversible. So we have to kind of set good expectation. And the pain, unfortunately, is not always 100% reduced. But if we are able to reduce it by 50%, I think that's a good achievement. You also have to think about the potential cost of being on the drugs, meaning that the side effects that you may suffer from. So it's a balance between benefit and side effects. As I showed you earlier, treatment results in better outcome. And you do a very good job at educating your doctors, by the way, because a lot of your doctors that are seeing you not the amyloid expert, but your PCP or orthopedic, etc., have only seen 1 or 2 patients with amyloidosis. So you can teach them about this disease, and they can potentially diagnose or refer other patients who they may suspect have the condition as well. And then finally, this is a complicated condition because it affects multiple organs. And a lot of time we have to involve our colleagues from obviously cardiology and neurology, but also from orthopedic, from physical therapy, from the spine center, GI, the eye doctors, and so forth. So thank you very much for listening, and I will stop here.
Thank you. That was absolutely wonderful. And again, I'll say it again in a couple of weeks. All these presentations will be up on our website and YouTube channel. And now we're going to hear about cardiac symptom management from Dr. Josh Mitchell. So Dr. Mitchell, take it away.
Thanks. So, again, that was an excellent presentation by Dr. Karam, and I'll shift gears a little bit to focus more on the heart. And we call it cardiovascular symptoms, but it's really, various cardiovascular effects of amyloid on the heart. And so we'll talk about the common cardiac effects of amyloid and what that means, what the impact is, and then some of the common management approaches. And I already showed you my disclosures on the previous slides. So when we think about the cardiac effects on the heart, are you able to still see the slide, Muriel? My green
Yes.
border went
Yes,
away.
we can see them. They're
Okay, perfect. So when we think about the cardiac effects of amyloid, it's important to sometimes think of why, and it helps us understand what's going on. And so when we have an amyloid heart, it gets really thick. Because it gets really thick, it's not able to pump quite as much blood. The heart doesn't relax as well. It doesn't fill up with as much blood. Because it doesn't fill up with as much blood, it can't push out as much blood. And so the amount of blood the heart is outputting drops. And because of that, patients can feel short of breath because they're not getting quite the same blood flow or oxygen delivery to their body, or they can also hold on to fluid. And that holding on to fluid is complex, but I think the easiest way to think about it that's at least reasonably correct is that when your heart pumps less blood, your kidneys see less blood. And when your kidneys see less blood, it thinks you're dehydrated. It's like, oh, the reason I'm seeing less blood and oxygen is I must be dehydrated. And so it holds on to fluid. And so then we have to sometimes treat that fluid retention with medicines like diuretics to tell your kidney, no, you do need to get rid of this water because it's having a problem. Because the heart gets thicker and can't relax as well, pressure builds up inside the heart. That pressure also builds up in the top of the heart. So here the thick heart is this bottom part of the heart. But amyloid also affects the top of the heart directly and also from increased pressure. And when that top part of the heart gets irritable, it can go into atrial fibrillation where the top's going like this. It's not squeezing well. And because it's fibrillating, it can make people feel worse because it's not squeezing blood well. And it also puts people at risk for clots. So we'll go over that some more later. We know patients with amyloid can often develop aortic stenosis. Some of this is age-related. As we get older, we're at risk for amyloid. As we're older, we get risk for amyloid, and also as we're older, we get risk of aortic stenosis. And some of it may be from direct amyloid involvement as well. But either way, sometimes we have to think about valve replacements, and we'll go over that some. And then Dr. Karam already talked about it some, but in some patients, you'll have lightheadedness with standing called orthostatic hypotension, and that also helps or will affect our management. When we think about management, it's always really important to realize that everybody is different. And this is just a random picture. It is not all patients with amyloid. Obviously, many of them are younger, but it just shows the diversity among the population. And so when we have an individual patient in clinic, some things may work for one patient and some things may not work for another patient. Some patients may have really high blood pressure when they're diagnosed with amyloid. Some patients may have really low blood pressure when they're diagnosed with amyloid. Some patients, for one reason or another, hold on to fluid, others don't. And so there isn't a one-size-fits-all approach. Sometimes it comes across that way. There may be a study that comes out that may say amyloid patients may not tolerate beta blockers as well, and we'll talk about that some more in the future. But many patients tolerate beta blockers just fine. And so we have to be really careful about not taking something to the extreme as we decide on our approach. And it's also important to know that everybody on this call may identify with some of these symptoms, but they may not identify with all of them, and they may never develop them either. So when we think of the first one, we think of heart failure. I purposely put heart failure in quotes because it's a terrible word. Every cardiologist hates the word heart failure. If I were to hear it and I wasn't a cardiologist, I would assume that I'm in an ICU somewhere about to die. And what heart failure means is that there's something wrong with the heart. It could be super small, to be honest. And as long as it has some effect on the patient, it either makes them a little more short of breath or it makes them hold on to fluid. It's called heart failure. So people can live with a version of heart failure for decades. It doesn't mean that you're in the ICU and you have days to live. But we're stuck with the term, so we use it. But when we see the term heart failure, it means that your amyloid in your heart is now making you feel short of breath or retaining fluid. When people retain fluid, the backbone of treating that has always been loop diuretics. Those medicines help get the fluid off. We usually start with a medicine called furosemide, but bumetanide and torsemide can be better absorbed and may be more effective in amyloid patients. There's not one that is always better. It's really what works the best for the patient. Because these medicines may only last a few hours, they can often be given twice a day. Because if you only give it once a day, in some patients, that's fine. But in other patients, they'll pee out the extra fluid, and then the second half of the day, they'll hold on to fluid. And so unless we redose that diuretic the second time, then they may not actually get rid of fluid. And so we often give it after lunch or in the early afternoon. We try to avoid, of course, bedtime dosing because that just makes you pee at night, and that's no fun. But now we have some newer medicines that help us with fluid, and that's the sodium glucose 2 cotransporter inhibitors and SGLT2 inhibitors, Jardiance and Farxiga. Those medicines will
Your
go.
slides are not advancing. We're still.
What slide do you see?
We were maybe on the third slide or fourth slide. There you go. Now we're
see
at
fluid retention now. All right,
Yeah,
let me know. I'll say I'm advancing and let me know. I'm not sure. This has never happened to me before, but awesome that it's happening today.
We have so many firsts on these things. You have no idea.
Sure. So we have the sodium glucose cotransporter 2 inhibitors, Jardiance and Farxiga, which help keep fluid off. They've been shown in heart failure patients in general, not just with amyloid, to keep people out of the hospital. And when we look at them in total, it may even help people live longer. And then we also have the mineralocorticoid receptor antagonists that also help keep fluid off. And so patients may be on a combination of these. Even though loop diuretics are the backbone, because of the extra benefits of the SGLT2 inhibitors, we often will want to make sure and use them, and some patients won't even need a loop diuretic once they're on their other medicines. Did this slide advance for you, Muriel?
Right. We're on sodium glucose.
Okay, perfect. So in this study, now patients weren't randomized to SGLT2 inhibitors. Whenever we do a study, we really want a study that randomizes patients. And so the studies that we've seen so far with amyloid, one patient was randomized to the treatment, another patient was not randomized to the treatment. Those are our best evidence for something being good for a patient. This particular study did not randomize patients, but it looked back and looked at a bunch of amyloid patients that were or were not treated with these medicines. And they try to do some statistical techniques to try and make it the same as a trial, but it's never exactly the same. With all that being said, patients who are prescribed these medicines seem to live longer, they stayed out of the hospital more, their kidneys were protected, they needed less of those loop diuretics as we talked about. And so the field on the whole has really accepted that these medicines likely have significant benefit in amyloid patients specifically, but also heart failure patients more generally. There have been those trials where we randomize patients in heart failure patients broadly. There just hasn't been a randomized trial specifically in amyloid, but you will see a greater use of these agents in our amyloid patients. Mineralocorticoid receptor antagonists have also shown benefit. This was also not a randomized study. It was looking back in a population of people who weren't or were not treated, and patients tended to live longer if they were started on these medicines. Spironolactone and eplerenone, they both help raise the potassium, so the loop diuretics lower potassium, and so the combination can be helpful. One downside of spironolactone is in some patients you may have some increase in breast tissue, both men and women, eplerenone does not have that same effect. It doesn't increase breast tissue, but it's less potent and more expensive. So we usually start with spironolactone. Now, if heart failure actually leads to reduced pumping, so everybody's amyloid heart gets stiffer, but some amyloid hearts don't pump as well. We do have a backbone of therapy for heart failure. Now, in the broader population, these medicines definitely help if your ejection fraction is 40% or less. It's been somewhat controversial whether these medicines help or not in the amyloid patients. And as I mentioned, sometimes people will say things like, oh, you can't use a beta blocker in an amyloid patient. But that's not really true, because as I said, some patients have high blood pressure, some have low. Everyone's a little different. And so the heart on your left is the heart of an amyloid patient whose ejection fraction was 25%. So that's low. A normal is 52% or higher, but she also had higher blood pressure. She was started on all of the heart failure medicines. She did great. Her heart function improved, and she continues to do very well. But there may be other patients that I treat that I start a beta blocker and they feel terrible, and then I immediately stop it. So we really have to individualize treatment, but we may use these treatments if your ejection fraction is low. In another not randomized study, but just looking at patients that were treated, if their ejection fraction was less than 40%, patients actually did better on beta blockers. Here's a couple of beta blockers that you may see, metoprolol and carvedilol. The concern with them is that because the heart's stiffer and it doesn't really have the opportunity to expand more, one way of getting more heart output is to go faster, and the beta blocker prevents it from going faster. But again, some patients do well. Other patients may not tolerate it, and we really have to individualize treatment. Another backbone of heart failure treatment in non-amyloid patients is this class of medicines called ACE inhibitors, angiotensin receptor blockers, and ARNIs. In this retrospective study, again, not randomized, there didn't seem to be a big difference in patients who did or did not take it. We don't really have great evidence to guide us except for in patients without amyloid. So we may use this, especially in someone with high blood pressure or the low ejection fraction, but we're also okay stopping it if people don't tolerate it well. So switching gears, let's talk about rhythm issues. And so medical term for that is arrhythmias, but that just means the regular rhythm system in your heart is no longer working. So normally that sinus node, which on the picture is in the top of your heart, it sends out a signal and the top of your heart beats and the bottom of your heart beats, and it's very regular. But sometimes things from amyloid can affect that. And so sometimes the heart can slow. Sometimes the bottom of your heart can be irritated and extra beats come from the bottom of your heart. Those are called ventricular arrhythmias. Sometimes the top of your heart gets irritated and can cause extra beats, and that's atrial fibrillation or some other potential issues. In general, if you have a slow heart rate, we may recommend a pacemaker, and that's a device that goes underneath your skin on the top of your chest, and the leads go around to your heart to help remind your heart to continue beating on a regular basis. If you have extra beats from the bottom of your heart and they sustain, then that can put you at higher risk of passing out or can even be fatal, and so your doctors may recommend a defibrillator for those. You know, one thought, and again, it's always controversial because everything in amyloid, people ask, does it work in amyloid patients too? And they do. So all these things are still used in amyloid patients, but we also recognize there can be specific things to consider in an individual patient. And certainly if a patient is highly at risk for ventricular arrhythmias, and if they're getting sicker, we may recommend the defibrillator to get turned off because the defibrillator can end up just shocking the heart multiple times, and we don't want that to happen. But in many patients, it can be a helpful tool alongside the rest of your treatment. Atrial arrhythmias are the ones that come from the top of your heart. We'll go through some more of that on the next slide, and I'll move to that now. So when we have atrial fibrillation or flutter, often the top of your heart is getting irritated. Some of that's because of increased pressure in the top of your heart. Some of that may be because of direct amyloid involvement in the top of your heart. In many patients, atrial fibrillation is poorly tolerated because the bottom of your heart is already stiff. The extra squeeze from the top of your heart is helpful, but other patients don't even know they're in AFib. They could care less. And really, our treatments for AFib are twofold. One, the most important thing from a cardiologist is to say, because you're in AFib, because the top of your heart's going like this, it's not squeezing well, You may have blood pool in the top of your heart and a clot form, and patients with amyloid are at especially higher risk for clots forming, so we're going to recommend a blood thinner, and we'll discuss that on the next slide. And then after that, we really focus our treatment on how you feel. So if you feel amazing, we may not recommend anything. We do want your resting heart rate usually to be controlled, and if you're having faster heart rates, we sometimes will slow them down with what's called rate control. But if you don't tolerate that AFib, then we'll recommend something called rhythm control, where we try to get you out of atrial fibrillation. Medications that we can use are listed, some of them, but that will be really individually targeted with your treatment team. We can do ablations, and that's where we go in through your blood vessel in your groin, and we go up around to where your heart is, and we heat up the tissue that's causing AFib, and that can help get some people out of AFib. It doesn't work as well as someone without amyloid, but it can work for many patients, and so we will try it. A maze surgery can technically be used and is more successful than an ablation, but there's no specific studies in amyloid patients, and so we would expect it to be a little bit less likely to be successful in amyloid patients, but may still provide benefit. And then as a last resort, if we can't control the heart rate, we will sometimes ablate that middle part of the heart, that yellow node in the middle of the heart, and that will keep the signals from the top of the heart going to the bottom, and then they'll get a pacemaker to tell the bottom of the heart to be more regular, and that can help control AFib in some patients. With all patients, we recommend blood thinners or anticoagulation, and that's because in the top of the heart, there's a small outpouch called the left atrial appendage. And when the heart is in atrial fibrillation, again, blood pools and stagnates, and a clot can form there. And if a clot forms there, it can come loose and potentially cause a stroke. And obviously, nobody wants a stroke, so then we recommend a blood thinner to treat that. And we usually use medicines like Eliquis or Xarelto, but sometimes patients may be on other agents as well. And there's some other medicines that are coming out that are like apixaban and rivaroxaban that I did not list, but those are the two most common ones. A couple more slides. This one is on aortic stenosis. So as I mentioned earlier, many patients with amyloid may develop aortic stenosis, but again, not all of them. Really, it's a minority of patients overall, but it is common. About 10% of patients who have aortic stenosis may have amyloid on biopsy. So we think about it in reverse too. Sometimes when we have an aortic stenosis patient, that's when we diagnose amyloid. If you have amyloid and you develop aortic stenosis, we generally recommend a valve replacement when it becomes severe. If it's mild or moderate, we don't generally recommend a treatment for it because there's no benefit to treatment at that point in time. We usually do it transcatheter, which means we go through the blood vessel in the leg most commonly and then go up around to your heart valve through your blood vessels to replace your valve instead of requiring surgery. But we can use surgical techniques sometimes. Many patients will have something called low flow, low gradient aortic stenosis, and that's because normally when we measure aortic stenosis, it's because there's a high velocity over that aortic valve because the heart's pumping really hard trying to push the blood out, and the aortic valve's not opening, and so that creates a really high pressure drop. But in some patients with amyloid, the heart's not squeezing as well, and so you don't have a big pressure drop even though you still have severe aortic stenosis. Patients who have low flow, low gradient aortic stenosis, they don't do as well as regular aortic stenosis patients, but they still benefit from a valve replacement. But most patients with aortic stenosis and amyloid will be typical aortic stenosis. It's a minority of patients who develop the low flow, low gradient aortic stenosis. And then the last symptom to discuss, and Dr. Karam already talked about this, but orthostatic hypotension. And so this is when people feel lightheaded when they stand up, and this can be from a number of factors that are cardiac that I'll focus on here. He mentioned some other treatments as well. But from a cardiovascular standpoint, our first question is, did we give you too many diuretics? Are we dehydrating you? And that may or may not be the case. It may be independent of that, but we always have to ask ourselves that question. And our goal when we give you diuretics is to get the extra fluid off, but not take too much off. And so if you start to get lightheaded and dizzy when you stand up, that may be a sign that we gave you too much. After we consider your volume status, we'll look at your other medicines, and we may start stopping or reducing some of those other medications I talked about or blood pressure agents. And then after we do those things, then we'll consider adding medicines like midodrine or droxidopa, which can raise your blood pressure. But we will always recommend physical countermaneuvers, as was previously mentioned. And so this can be just getting up slowly. This can be squeezing your belly muscles when you get up. You can squeeze your arms. And if you're squeezing your belly muscles in your arms, I kind of think of that as the Hulk. And that can help raise your blood pressure, maintain it as you stand up. It can also potentially help to cross your legs. And then it was also mentioned previously that sometimes binders can help, but certainly compression stockings can help. So in summary, patients with amyloid can develop several heart effects, heart failure, rhythm and valve abnormalities, or low blood pressure. There are some general guidelines on management, but it really is important to individualize treatment. And your symptoms may vary throughout your duration of your illness, and we certainly want to adjust medicines as we need to. And your treatment team is there to help you through your journey. Thank you.
That was wonderful. And again, we'll have all the presentations up there in a couple of weeks on our website, amyloidosissupport.org, and on our YouTube channel. We're going to switch around our agenda a little bit because Paula has asked to go last because we've got some hard stops for our doctors here. And I don't want to, get in bad with them guys. So, if I promise them a certain time, I want to, well, you know how that goes. Okay. We've got a gal, Maren, who's going to be leaving early. So she asked that we ask her question first. So we're going to do that. And she has a balance problem. She's not dizzy like the world's going around, but if she turns too quickly or she's walking and moving around, she notices it. And it's a problem for about a year. Now, does this relate? She doesn't say whether she has ATTR wild type. What? Oh, no, she has wild type. Okay. So what do you think might be Maren's issue? Any volunteers here? Or I'll assign a volunteer. Dr. Ruberg, what do you think?
Off mute here. It sounds like that the dizziness is related to positional change and not. So we think, as was discussed by Drs. Mitchell and Karam, that we think about positional change with getting up quickly, and that can lead to something called orthostatic hypotension, which we talked about. That's just basically related to lower blood pressure. But as was described by the question, I'll let Chafic answer, but it sounds more like this is kind of like turning the head, which would be a different positional sort of dizziness. Dr. Karam, do you want to comment on that? It doesn't sound like this is a blood pressure issue.
Yeah, I totally agree. It can be sometimes hard. We know how symptoms of something present, but can be a little bit difficult sometimes for the patient to report exactly what we think, and we don't want things to be lost communication. But obviously, the easy thing is to make sure that the blood pressure is not dropping. But I totally agree with Rick, is that if you stand up and you feel fine, and you walk and you feel fine, but every now and then when you turn in certain situation, you feel that you're not fine, then a lot of time this could be coming from the ears. And in those situations, we do recommend some vestibular rehab, for example. So, but the easy thing is just to check the orthostatic hypotension. But again, I agree with Rick. It doesn't seem like it is really a drop in the blood pressure that's causing the symptoms.
Okay, great. Here's a question about Amvuttra and itching. Okay. Edie says shortly after her first injection, her head scalp itched constantly. Have you heard anything about itching with Amvuttra? And is that something they should be reporting to the people that make Amvuttra? And Dr. Mitchell, we'll go with you on this one.
Sure. So I have not run into itching with Amvuttra in my patients, but I think it's always possible to have itching with many different medications. And if the patient seems to have developed the itching right after starting Amvuttra, or the time related, then that would be an important question. Certainly discussing it with their doctor, potentially seeing a dermatologist or primary care. And if it really is felt to be with Amvuttra or not, it's always important to report it up to see if it's one of a series, because sometimes it's the first patient says, hey, I'm having this symptom, and then someone else says, I'm having that symptom too, but I didn't want to tell anyone, that we start to collect more data on that. Dr. Ruberg or Dr. Karam, have y'all run into much itching on vutrisiran?
Not in the scalp. I mean, this is, you can have itching where you inject the drug for, 24 hours and then goes away, but not in the scalp. Actually, what makes me think about itching in the scalp is a side effect very well known to midodrine. So midodrine, which increases the blood pressure, and we give it to people with orthostatic hypotension, is a classic in very many patients cause itching of the scalp. So I wonder if she started two drugs at the same time, which is why I don't like to start two drugs at the same time. Start one and then see what happened, and then the other. But something to keep an eye on for sure.
Yeah, I don't have anything else to add to that. Site itching at the site, but not at the scalp. I've learned
Okay.
something from Dr. Karam. I did not know that about midodrine, so thanks for telling me that.
But
Yeah, I didn't either. Yeah, okay, that's okay. You heard it here, folks. Okay. Now this is an interesting question because we always hear about, if you're on a silencer, you have to take vitamin A and, either in a multivitamin or whatever version your doctor tells you to take vitamin A. But this person wants to know about thyroxine because TTR transports thyroxine. So what is thyroxine not necessary? No one ever tells me to take a thyroxine additive of some kind. So Dr. Mitchell, what about thyroxine?
yeah, no, it's a great question. I found this whole development of the silencers to be fascinating because, if we just back up a second, we have the transthyretin protein and it helps us transport thyroxine and retinol. So it's involved both in thyroid and in vitamin A. But we found over time that the impact it has on the thyroid axis is very minimal. And so we have not shown any clinically significant effects on the thyroid axis. At times, in some studies, they've noticed some mild changes, but in the end of the day, it's never affected. It's never caused low thyroid. And so it's just been the vitamin A that has the bigger impact. But fortunately, to date, we've been able to address that by vitamin A supplementation. And I'll just quickly add, because I know there's another question by Mr. Miller about CRISPR-Cas9. And so, yes, if we turn off transthyretin from any reason with CRISPR-Cas9 or with the silencer, patients do have to take just the recommended daily allowance for vitamin A. And so patients who get the Cas9 treatment would need to take lifetime vitamin A, just a regular daily allowance.
Okay. Now this person Lou has a question about spinal stenosis. He frequently sees it referenced as a symptom. Okay. He's had 2 fusions and continues to have pain. His surgeon claims he does not have spinal stenosis, and the surgery looks perfect. So I'm not sure. He'd like you to basically comment on spinal stenosis and amyloidosis. And then he has another question too, but let's go to that one first.
I guess I'm gonna take it. Or Rick, do you want to take a stab at this?
I think there's two parts to the answer. So Chafic, you can answer about the symptoms of spinal stenosis and the management, and I can talk a little bit about how spinal stenosis relates to systemic amyloidosis and the subsequent development of cardiac amyloidosis. So maybe Chafic, you go first because it sounds like it's more of a symptomatic question.
Yeah, I mean, spinal stenosis is basically almost like, if you think about it, carpal tunnel syndrome of the spine, right? So you have tightening around the nerve roots that carry the signal from your brain down to your legs and down to your arms. Usually, spinal stenosis is more common in the lumbar spine, meaning in the lower back, but it could be at the neck as well. The issue with pain and spinal stenosis is complicated. The surgery can be very successful, but the pain can persist. And that's a very well-known fact. And I always tell my patients, if you're just going for the surgery for the pain, it's not guaranteed that the pain is going to get better. But if you're going to the surgery because the spinal stenosis is pretty bad and it's impacting the signal, then it is something to worry about. Okay, now you're stuck with this. They did the surgery was very successful, but you're stuck with pain. What do you do? There's a few options that you can do. Physical therapy is always recommended. Strengthening the muscle of your back will be helpful because that will take off the pressure on the bone, which is what's causing the arthritis and the pain. That's number one. Sometimes you have to go gentle, aquatic exercise, for example, in the pool or something like that, physical therapy. Every now and then, some people benefit from injection in the lower back. They do a steroid injection where it hurts and helps. Sometimes people will not benefit from anything. They need a spinal cord stimulator, another invasive procedure. Sometimes medication can help. Okay, chronic antidepressant can help. And sometimes you also need some therapy for that. So I will stop here. Many options, though, to try to relieve the pain.
Right. So all great advice there. And I'll kind of answer the question about what is the significance of spinal stenosis in the context of just ATTR amyloidosis in general. And so I think it was Dr. Karam who said in his presentation that amyloid is everywhere when people have systemic amyloidosis. And that is true. If you start, putting needles in different parts of the body, you're going to find it. And for reasons that we don't fully understand, in some people, the amyloid collects in ligamentous structures. Ligamentous structures are things like this, the carpal tunnel and the ligament that runs along the spine called the yellow ligament. And when those ligaments get thickened, they push on the nerves and they cause the syndromes of the neuropathy that Dr. Karam treats. And often, the treatment for that can be medical, as he just discussed, or surgical, where you basically cut away the ligament and release the pressure on the nerve. Now, it was kind of observed that patients with cardiac amyloidosis from ATTR had a higher proportion of ligamentous amyloidosis, both in the carpal tunnel and in the spine. And there are a couple of papers that have looked at studies that have looked at this. And the general kind of thinking now is that ligamentous amyloid precedes the development of cardiac amyloidosis by about 5 to 10 years. And that's been shown by a couple of different studies. Now, that's true if you look at people with cardiac amyloidosis, but there are like 1 million carpal tunnel releases done in the United States each year and hundreds of thousands of spinal stenosis surgeries for ligamentous resection. And we don't know what proportion of patients of that big group will ultimately develop systemic amyloidosis and cardiac disease. And there's a number of studies that are beginning to look at this. Some of them have been published, some of them have not. I'm part of a large one that's looking at the lumbar spine that's run by Dr. Maher at Columbia. And I think we're going to try to understand of the people who have lumbar spinal stenosis and how many of them have amyloid deposits and how many of them then ultimately develop cardiac amyloidosis. So it's kind of a very multi-layered answer to a question which I think is like we just don't know the answers to. But I hope over the next couple of years we'll have some clarity on what is the significance of amyloid in the carpal tunnel or in the lumbar spine in terms of ultimately causing, cardiac amyloidosis, and how to treat it is a whole other question, which I will not get into right now.
Okay, yeah, there'll be a lot more detail in October on everything, folks. Okay, here's a question for a hereditary patient on pain. They have, I don't know what this is, VEXAS, VEXAS. Does anyone also have patients with this disease? Now, let's get that. That's the first question. Do you know what that is, anyone? Or can we, no? Okay, so you.
Sorry, VEXAS?
Mm-hmm. VEXAS, right.
Yeah, that's not amyloidosis.
Okay, so it's a different disease.
Yeah, and they may have both, but yeah, go ahead. I'm sorry, go ahead, Chafic. They may unfortunately have both, but they're not generally seen together.
So it's kind of bad dumb luck, right? Okay.
Yeah.
And the next question is, I have terrible pain in my feet at night. They have Val 30, Val 50 met. They're on Amvuttra and Attruby. They tried gabapentin, Zymbalta, Lyrica, oxycarbazepine, lidocaine infusions, Oxycontin, naltrexone. Wow. Okay. Any suggestions?
So there's more to try. I mean, that's a suggestion, is that we have, about a dozen of different medication that we can try for pain and amyloidosis. And sometimes a combination of therapy can be helpful. The other thing that I see frequently is that people don't get on high enough dose. So they take gabapentin, 100 milligrams 3 times a day or 300 milligrams 3 times a day. And they're like, well, that's not helping. Let's switch to something else. That's not a very good approach, because gabapentin, you can go to 1200 3 times a day. What if that dose helps? So, I need a little bit more details about what they have tried, and sometimes in combination. So, for example, if you try a gabapentin with duloxetine or with nortriptyline, etc., you can have a synergic effect on the medication. We have to also remember the alternative treatment that we discussed: massage therapy, acupuncture, soaking your feet, etc. And then, when everything else fails, then you can discuss with the pain clinic potentially trying a spinal cord stimulator and see if that helps. What they do a trial first before they do the invasive procedure that puts a permanent device in your body, which is basically a pacemaker, but for the spine, and kind of confuse the spine, and the signal of pain doesn't travel to your brain. So that's the idea behind it. So Optimize the dose of the treatment, make sure you're on the maximum dose, try to do combination therapy, try some alternative stuff, and everything's failed, discuss with the pain clinic what alternative options you have.
Yeah. Here's an interesting question. Okay, this person is expounding on the theory that they're taking Amvuttra, which is going to silence a certain percentage of their TTR, and then whatever percentage does not get silenced, this is their theory, then meets the stabilizer that they're on, and it gets stabilized, whatever's left. So then they feel that they're that would leave them an exposure to future fibrils of about 1%. Is their math correct? So I'm sure you've heard variations on this over the years, but all right, we'll ask Dr. Ruberg and then we'll ask Dr. Mitchell. What do you think?
Well, I think that the calculation, it's difficult to know whether the calculation is correct because, and I'll explain why, but the concept of using both together is one of the things that I mentioned as an unanswered question. And it makes sense because as I showed you in the curves, the kind of the outcome curves, even patients who are on treatment still experience adverse outcomes, meaning that unfortunately some people will ultimately die of amyloidosis and some people will get hospitalized for heart failure. So eventually, so it suggests that just one strategy is not enough. So, and we often will do that at our center where we will, in certain individuals, have them take both a stabilizer and a silencer with the concept that you knock down TTR by like 80 to 85% on vutrisiran, and then you stabilize as much as you can with what's left, either acoramidis or tafamidis. How much you're stabilizing, though, is not clear. Because again, I think I mentioned, like, there's in vitro assay. So basically you put it in the test tube and you can do some fancy chemistry testing to figure out what's stable and what's unstable. But in the blood, it's a little harder to know. So you can't really say that, okay, well, vutrisiran stabilizes more than 90% of ATTR. And so therefore, if you're taking that, and there's only like 20% left, then it's 90% and 20%, which is the calculation that this person very, kind of thoughtfully just did. I don't think it works in practice that way, but in principle, the idea is exactly that. If you can stabilize what's left, you will further slow down the development of disease. None of the studies have yet shown that definitively. And that's something that I think is an important unanswered question.
Dr. Mitchell, what are your thoughts?
No, I completely agree with Rick, Dr. Ruberg. We have two, I guess, issues. One is that at the time we start treatment, the patient's already had amyloid. Their heart is already thick. It already has the impact of the amyloid. And, even if we just use one agent like tafamidis or acoramidis or vutrisiran, it has an effect. And if we take a stabilizer by itself, it stabilizes around 95% of the protein. So when the patient ends up getting hospitalized or dies, is that because of what they've already experienced before we started treatment? Or is that because they have 5% of the protein that's not been stabilized? And so as amyloid experts, we all theorize that doing both is better. We don't know that both is better. We all look at some of the sub-studies and some of them may point to both being better, but we really don't know yet. And that's why these upcoming trials are really important that continue to look at whether dual therapy, whether adding nucresiran in the Triton trial or the CardioTransform trial didn't really randomize patients, but will give us more data on trying to sparse this out. But it is an interesting question. I think some of the fascinating things in future research will be inside the body testing better, how much amyloid fibrils are still there and what the end effect is, but more to come. But certainly we all like the concept and we do hope that we can continue to find ways to better treat patients.
Okay, thank you. And Dr. Karam, do you have anything to add to that on the dual treatments?
No, I think I agree with everything that has been said, but obviously, I always try to reassure people that if they're on one drug that's pretty good, I don't think we should really obsess, given the lack of evidence that you need two drugs, and sometimes the copay can become pretty expensive. We have kind of looked, the truth of the matter, a lot of people end up on two drugs. About 40% of our patient population at Penn is actually on two drugs. And we looked back, it's a retrospective study, so obviously it has a lot of flaws, but we didn't see really a major difference between people who were on both drug and who were on a single therapy. So hopefully I can reassure people that as long as you're on something, I think that's a good thing.
Okay. And you all put up charts that, showed that the certain drugs that, at 18 months, this is what happened. And then at 24 months, this is what happened versus placebo. But this person wants to know, how long does it take for them to become, for Truby and Amvuttra to become fully effective, or is that something we don't know yet? Dr. Mitchell?
We have pretty good data that it's fairly quickly effective. Now I can't necessarily tell you the day or the hour, but we know that especially in the more recent trials, we've done even more testing. So in acoramidis, we see a significant impact within 30 days of starting treatment, and that correlates to a very quick separation in whether people are doing better or not on treatment. And so people start staying out of the hospital more within a few months of starting treatment. And we know with the silencers, we see a pretty quick knockdown of the transthyretin protein. And while we don't have as detailed evidence from the original ATTR trial with tafamidis, we also have every reason to believe that also starts working pretty quickly in the body to help prevent future issues.
Okay, here's a question. Wild type with neuropathy, no cardiac. Okay, and we see this a lot in our Facebook groups. We're seeing a lot of patients with wild type, and because the neuropathy drugs are approved for hereditary with neuropathy and not wild type with neuropathy, except for Amvuttra now, which kind of crosses both. So, but this question is, what treatments are available for confirmed wild type ATTR with polyneuropathy, but with no evidence yet of heart involvement? So, Dr. Karam, what are your thoughts?
Yeah, well, we don't have anything approved, so this has not been studied very well. And it's a little bit difficult, and I'll tell you why. Wild type neuropathy is just common in the general population, and as you get older, it becomes more common. So about maybe 5-10% of people over the age of 75 or so will have some evidence of neuropathy. And there's hundreds of reasons why people can get neuropathy. So the question is this really related to the wild type or not? You have to really prove it. And how do you prove it? You do a nerve biopsy and look under the nerve biopsy and see if there's actually wild type deposition within the nerve, which has been done many times, but we have not found yet amyloid in the nerves. So it's an interesting question, and I don't really have a very good answer. As Dr. Ruberg was mentioning with the spinal stenosis and carpal tunnel syndrome, if you find wild type there, well, what do you do about it, right? If it's not in the heart, do you treat it or you don't do anything? We just don't know. Obviously, the question is, would the treatment of, if it's wild type, would the treatment of amyloidosis help? Obviously, it should in theory. But that's a complicated subject, very fascinating, by the way, but I don't have very good, Now, if somebody wants to start diflunisal, that's a totally different thing, right? It's a stabilizer, it's off-label. We know that it helps, and you don't have to get it approved through the insurance, so that's a potential option. Yeah, but I don't really have any smart thing to add here. I don't know if Rick or Josh wants to say something about that, although it's a neuropathy, but let's say it's carpal tunnel syndrome. What do you do for it?
Well, I'll at least briefly chime in that I think, so I completely agree with you, Chafic, and we need to learn a lot more. I will say that I've started to see a couple of patients. I've had one that for sure has wild type neuropathy on nerve biopsy, happens to be a woman in her 60s to 70s, actually. And then I had another one who has amyloid on her carpal tunnel biopsy and neuropathy, and there's a question of amyloid, but we haven't proven it yet. And so I wonder if we start to look for amyloid more, we're going to start to find these patients that truly have wild type neuropathy, where historically it really wasn't felt to have that much nerve involvement. But either way, to Shafiq's point, we haven't proven what works in those cases. We certainly would expect amyloid stabilizing or silencing therapy to help, but we're not going to be able to prescribe it until we show that in some sort of evidence. And so until then, it's more of an expert opinion approach. And in those cases, I certainly would lean towards diflunisal. So my overall approach in that patient is, one, to make sure I'm not missing a different type of amyloid, if it is amyloid or I'm not missing a different comorbidity that's causing the neuropathy, that I've tried my best to diagnose heart involvement. And then if I don't have a approved indication for an amyloid stabilizing or lowering therapy, then I will consider diflunisal and talk about that with shared decision making since it hasn't been proven.
Yeah, I would just echo the points of my colleagues. I think that remember when we're talking about neuropathy, again, I'm not a neurologist, you know this, but there's the compressive neuropathy from carpal tunnel and spinal stenosis, which is different than the neuropathy you get, say, in variant disease, which is the nerves themselves are affected by amyloid deposits. And you can see that either through a nerve biopsy or a skin biopsy that show of the epidermal nerves. And so if that has been shown in that manner, then the patient would, then they would have wild type. But I do think it's very difficult to disentangle the other causes of peripheral neuropathy that occur in older people that are not amyloid related. And I think diflunisal is a very viable treatment option in that particular case. I think diflunisal for compressive neuropathies is a different story because, as I mentioned before, we don't know what if they don't have cardiac disease. That's the other thing. So we don't know what proportion of people who have the compressive neuropathies, the carpal tunnel and the spinal stenosis, are going to progress to cardiac disease or a direct neuropathic involvement. And that's where it's kind of a gray area. And sometimes at our center, we're using diflunisal and sometimes we're not. And I think it depends on other sorts of risk factors we could talk about longer. But it's a good question, and it's another one of those unanswered questions.
As a really quick comment, those are all excellent points. As a really quick comment, I have a patient with V122I neuropathy without significant heart involvement, and she's on ATTR therapy, and she's actually on dual therapy because she had enough heart involvement to get approved. And so I told her to stop diflunisal, which had been started earlier, to try to prevent competitive inhibition with tafamidis, just because we don't know better. And she stopped diflunisal and had significant pain, arthritis come to her, and she restarted diflunisal and felt way better. And so I just bring that up to say that sometimes diflunisal can also help with some of the pain related to the disease.
Right. Well, it was originally an arthritis drug, I guess. So, okay. So what basically we're saying here is we need an ACT early trial for wild type as well as hereditary, right? Isn't that what we're saying?
Well, ACT early is for hereditary, so that's covered. But for wild type, I think, it's trying to figure out who are the people to treat, and that I think we just don't. I mean, if you have legitimate amyloid neuropathy, either, as I said, by like epidermal skin biopsy with amyloid deposits or a nerve biopsy, which isn't commonly done anymore, or someone like Dr. Karam says, I think this is amyloid neuropathy, an expert, then I think we need to understand those people should be treated. And the question is, with what? Because there are really no kind of approved therapies, and that's where you can use diflunisal. But preventing disease is going to be. We all have wild type if we don't have variant, because that's by genetically the same. So how do we decide who are the people at risk? That's kind of the challenge.
I think the people, if we have patients out there that were just diagnosed because of carpal tunnel, they saw the awareness stuff on television or heard it on the radio. They have carpal tunnel, they got tested, and they do have wild type, but they don't yet have cardiac symptoms. They don't even maybe yet have neuropathy symptoms, but they do have proven TTR because of the carpal tunnel. We could do an ACT early trial for those people. And
I see what you're saying. Yeah, no, that makes a lot of sense. The reason why I was confused is because to get into ACT early, you can't have amyloid anywhere.
right.
So the patients you're describing already have amyloid in their carpal tunnel. But you're right. You're basically saying preventing the development of cardiac disease or other neuropathic disease. So that, yeah, absolutely. And that's kind of what we're trying to, there isn't a randomized trial. Of course, you have to watch for a long time. And that's where these like retrospective studies can be helpful and to try to understand who are the people most likely to progress.
Okay, thank you. And now, Vindamax versus Attruby here. And you went into that beautifully, showing that in vitro, of course, in vitro is one thing, right? And in human is a whole other story. We know that, right? But this person has wild type, was diagnosed 6 years ago, and because of insurance issues, they're covered by Vindamax, but not Attruby. But they're kind of excited about the Attruby results, so they're wondering. which would be better? Should they be happy with the Vindamax, or should they, should they switch over to Attruby? What's going on here?
That's such a yeah, that question. I should just duck it and let Josh answer. But well, I mean, I think that the messages that I would say are, number one, if you're on Vindamax, you're on an effective therapy. Okay, we know that. The trial demonstrated that it works. There's a lot of data that I didn't show because for time that shows that if you're on it, especially if you're early stage, you do really, really well. And so it's an effective drug. It is possible that acoramidis may be more effective because it is theoretically a more potent stabilizer. But we just don't know that yet. So I would say it's somebody who's like doesn't have the decision made for them, meaning the insurance company is making the decision. You're on a drug that's working. It's okay. As long as if there's evidence of you're getting worse, and as I said, that's also an unanswered question. But if, say, for example, you get admitted to the hospital for heart failure, or your echo numbers get worse, or your NT-proBNP gets higher, or other sorts of things, then you can make the argument that maybe you should be switching. Okay, but we don't know that yet for sure. If you're in a situation where you can get either drug and they cost the same to you, then it becomes a question of, well, do you want to take a drug once a day or twice a day? And if that doesn't matter, then honestly, either of them would be okay. And so I often tell patients, those are the kind of the layers of decision making at this point. Until we have head-to-head data that shows that one is better than the other, at this point, it becomes a question of what's the most cost effective to you, and do you want to take a medicine once a day or twice a day? And I'm not even talking about Amvuttra, which is obviously every 3-month injection, and it's a different sort of type of. But the two stabilizers, those are kind of the questions. And and understanding it might be true that acoramidis is better. We just don't know that yet. And I think at this point, I and my colleagues are not recommending necessarily one over the other definitively. And as I said, you could make the argument that certain situations, like somebody who's got a variant that we know is particularly progressive, like V142I, you could maybe make the argument that acoramidis might be better. But again, nobody has looked at this yet and shown this yet. So that's my long-winded answer. I'll let Josh answer.
A very fair answer. I think that no matter what we say, we should say that we don't really know because we don't have any head-to-head data, and so we should be very careful about overly recommending one versus another because of that. I will say that the stabilization data for acoramidis in hereditary patients is pretty convincing. It's not head-to-head, but if I have to pick between the two, then I would lean towards acoramidis in hereditary patients. I haven't seen convincing data that it makes a difference in wild type patients. And if a patient's doing well on tafamidis, I certainly don't recommend changing it in those particular cases. But the hereditary patients are the ones that it certainly leans towards acoramidis in my book. And then we were really hopeful at times that we're going to get a knockout difference, that we could know which one was better or not. And I don't think we've seen that yet. I think all three are amazing drugs. All three make a huge difference. All three are great for patients. Even if acoramidis does end up being a better stabilizer, especially in hereditary patients, which we need more data, as Dr. Ruberg says, tafamidis remains is an amazing treatment that really transformed the disease state for lots of people.
Okay. Now, Josie has a question about connective tissue. Okay. She feels that a lot of talk is about the heart and the nerves, and GI and kidney sometimes come up, but she says that she feels that connective tissue is neglected here. And so maybe you could go into what connective tissue is and how it might be affected in ATTR. So Dr. Ruberg, take it away.
Sure, and I think I might, I also would bring Chafic into this discussion too, because a lot of times the connective tissue manifestations are the ligamentous manifestations. When we talk about connective tissue, we talk about like soft tissue. Connective tissue, I think by definition, are things like ligaments that connect bone to bone, or tendons that connect muscle to bone. And so that's kind of what we're talking about. But there are other, soft tissue manifestations we haven't talked about, like trigger finger, which is another one of those like deposits that causes ligament, kind of the ligament to, the tendon or the ligament to develop kind of contracture, and that's treated with surgery. But when we talk about connective tissue, we're generally talking about like the tendinous and ligamentous structures that we've already been discussing. There is also potentially a signal, and this is like not clear, about deposition of amyloid in the kind of the articular surfaces of joints that potentially could precipitate the need to replace joints more. But I think that that's not been really kind of definitively shown. And so meaning that because joint replacements are common, hip replacements, knee replacements, the people who have systemic amyloidosis have more commonly hip and knee replacement. There's been data that suggests that that's true, but I think it's kind of gets to that point that Dr. Karam made earlier, is that the amyloid is kind of deposits kind of everywhere, and it kind of focuses in certain places. And that's kind of, I think, what we're talking about when we talk about connective tissue and soft tissue. Chafic, anything you want to add to that?
Yeah, no, I think you've explained it nicely. I mean, one of the very common thing that we see, and especially in wild type, is the rupture of the tendon of the biceps. So people all of a sudden, they feel like a pop here, and then they have a bigger biceps because it's retracted. And that is one of the manifestation of soft tissue deposition, if you want, of the amyloid. These things are a bit more difficult and less standardized to follow, like in a clinical trial. The neuropathy, we have specific measurement. For the heart issue, we have specific measurement. It becomes a little bit more complicated when you're looking at ligaments, and especially which ligament are we going to look at. But at the end of the day, we know, and we think at least, that a lot of the disease start really probably depositing in the ligament and other organs even before the diagnosis is made, sometimes many years. I mean, if you think about carpal tunnel syndrome, it can happen, which is really a soft tissue deposit of the amyloid, not in the nerve, but in the ligaments around the nerve, and compressing and making it tighter for the nerve to be in that area. Can happen many years before the diagnosis is made. So it's a very important topic and definitely understudied.
Okay, thank you. Well, we're 2 minutes away from Dr. Ruberg having to leave us. And I just want, that reminds me, I just want to say that we really appreciate you joining us, this morning and this afternoon. We know that it's Saturday, it's summertime, you have families, you have things going on. And it means a lot to all of us that you're willing to give your time to this, and we don't take you for granted. Well, maybe we do, but we really appreciate that all of you. We really do. Let's get one more question for you, Dr. Ruberg, before you say goodbye. Okay.
Sure.
And here's a question about Canada. Well, there, and I don't know if any of us can answer this. But this person in Canada is concerned because all the trials seem to be happening in the United States. Can Canadians be included in the American trials? Now, you have a lot of trials at BU. Do Canadians come down for those trials?
Yeah, they do. And I think that generally, there's no exclusion to being outside the United States to participate in clinical trials. And there are major amyloid treatment centers in Canada, like in Calgary, for example. So I think that, I think that there is access to treatment trials, and I think if you happen to live close to the U.S., you could also potentially get to one of the northern, cities, any one of our cities, except maybe St. Louis, maybe a little bit far south. but I think airplane people can.
We have a direct flight from Canada to St. Louis, Dr. Ruberg. You don't have to discount.
Oh wow! I
should have guessed that there would be. No, I think that it's a really important question about access to trials, and a lot of the trials were actually done outside the United States that we talked about, because that's where it was easier to enroll people. Also, most of the people in the United States who were enrolled were probably, for example, in the placebo arm after tafamidis, were ultimately on tafamidis because that was what was available. So, and the last thing I'd say is that the approvals in Canada tend to follow the approvals in the United States. So, I think always reach out to a center, irrespective of where you are, and the center will do what they can to try to enroll you in the ongoing trial.
Okay, so we will say goodbye, and thank you so much, Dr. Ruberg. We really appreciate you coming, and Dr. Karam, I know you have to leave soon, so I'll try and find some neuropathy questions for you. Okay, take care.
Thanks so much, and
go ahead.
I was going to say thanks so much, everybody, for joining today. I hope to see many of you in Chicago in a couple of months, where we can interact in person. And it's great that that Muriel, you organize these meetings. And for us, it's really, I personally, and I know that Josh and Chafic feel the same way. It's just super important for us to speak directly to you and hear your questions. And it's one of the most rewarding things that I do in this job. So I'm grateful to have the opportunity.
Oh, we appreciate that. Thank you so much.
Have a good day, all.
Bye-bye. Till October.
Till October.
Okay.
So I'll
And
just briefly, Muriel, if you don't mind, I'll briefly answer the clinical trial and just broaden it for the group. If anyone on here is interested in the clinical trial, I think first you can reach out to the center that's closest to you and ask them if they're enrolling, and hopefully they'd be able to point out a close center that is enrolling. But if not, you can always reach out to any of us to help, or reach out to the company itself. But I have patients that travel to St. Louis sometimes for these trials, and as Dr. Ruberg mentioned, he has patients who even come from Canada for his trials, and so everyone's welcome. Many of these trials are international, as he said, and so I'm not as familiar with Canadian sites, but I do know they're worldwide. So hopefully there is one closer for you too.
there you go. Okay. Dr. Karam, this person asked if Amvuttra, we know, is directed at stopping the liver from making TTR, but this person wants to know if it can help with pain. Do some of these drugs seem to show that sort of tendency to help more with pain, or is this just a hope here?
They could. I don't tell that the patient because I don't want to promise. And the issue is that if you already have nerve damage from amyloid, the nerve are just going to be irritated. So, but I have seen some people improve, but I wouldn't say that's the majority. Sometimes the pain need to be targeted with additional treatment, as we discussed before.
Okay. And okay, we have that. Okay. What are the best strategies for preventing or avoiding bicep tendon rupture? So in other words, if someone is diagnosed with ATTR and they think that their particular type might lead to bicep tendon rupture, is there something they can do to prevent it?
Well, that's a great question. I don't have an answer for that.
They want to know strengthening exercises, wrapping, avoidance of a certain sport like tennis or golf.
Yeah, I don't know. Josh, do you know?
I don't know, but I'll jump in with some potentially helpful recommendations. Number one, whenever we study things that say, hey, this person might be at risk if they exercise, should we tell them to sit on the couch or be in bed? It's always worse to sit on the couch or be in bed. So we definitely want patients to stay active. If we just kind of think through the risk of a biceps tendon rupture, we certainly wouldn't tell you to carry something much heavier than you're used to all of a sudden. Maybe that puts some extra strain on the biceps. But if you're doing routine things that you do often, or if you're even doing strength training and slowly, gradually increasing your strength, then that should be overall well tolerated. So just be thoughtful as you do your exercises, but we would definitely recommend you stay active. Your overall risk of biceps tendon rupture is low if you take all TTR patients, even though it's a sign of potentially having amyloid. The majority of my patients have never had a biceps tendon rupture.
Okay. Okay, that's cardiac. We'll see. Dr. Mitchell, we're going to keep you on for an extra couple of minutes, okay? Okay, now this is something that comes up all the time. Dementia and mild cognitive. Now we know there are types of amyloid, different types that are amyloid that affect the brain. There's cerebral amyloid angiopathy, there's Alzheimer's, which is another weird type of amyloid. But this person wants to know, does amyloidosis contribute to MCI? Does amyloidosis cause oh, this is another question. So let's go with, does amyloidosis contribute to MCI, which is mild cognitive impairment?
Yeah, that's an important question. Not very well studied, but we do know that the amyloid can go to the brain as well, right? Because it's produced in the brain. And I think as people are living longer, because they are successfully treated with the current therapy, there's some signs that they are exhibiting more and more, brain disorders. So The unfortunate answer is that it is probably contributing a little bit.
Okay. Okay. Now, does amyloidosis cause frequent constipation? Well, that would fall under the autonomic neuropathy, right? With the GI issues. Okay, so we know that. Okay. Veins. Since my hereditary ATTR diagnosis, I've noticed a strange pattern in my veins. 3 raised lines. Does amyloidosis enter the veins?
So I guess similar to the mild cognitive impairment, venous effects of amyloid haven't been real studied. We do know it's possible for it to affect the vasculature, but since varicose veins can happen in patients with and without amyloid, it certainly may be independent. It could be related to increased pressure in the blood vessels. It's one of those things that's tough because some of your questions, Muriel, if we say that amyloid can cause mild cognitive impairment, then everyone on the call is going to think they're going to get mild cognitive impairment, and most of my patients do not have that. But since amyloid can travel everywhere because it's somewhat individualized, it is always possible if someone has something that amyloid may have contributed to some extent. But at least I would always be cautious to make everyone worried that they're going to get venous issues or if they're going to have dementia as well.
Okay. Liz says, my husband's in the clinical trial ALXN2220. If this drug is effective, will it be taken forever or is it designed for a set time? Is it safe to take a depleter, stabilizer, and silencer at the same time? Well, that's a separate question. Okay. So the 2220 trial, okay, will it have to be taken forever or just a set time?
And so I briefly mentioned that during the slides. We don't know. Currently, it's being studied as an ongoing infusion every 4 weeks for 2 years. But the company doesn't quite know yet how they're going to approach it post the study. So assuming the study is positive, and we certainly think it will be, whether it's something that just needs to be given for 6 months or not, we'll get a lot of data from the study. So if we see significant improvement in patients after 6 months across the board, then maybe we just need to give it for 6 months. But we'll really need the data from the study to try to guide that, and then plus how the FDA approaches approval.
Okay, and is it safe to take a depleter, stabilizer, and silencer at the same? Well, we certainly hope so, because that's the right.
As far as we know, it currently is. We'll certainly have to review the adverse effects from the trial when they're published. But many of the patients are on all 3 on the study.
Since wild type amyloidosis is a result of a faulty liver, well, I don't know if the liver's faulty, but it's making a rogue TTR, right? Should drugs such as Tylenol be limited?
I can answer that unless Chafic wants to. So generally speaking, Tylenol is actually safe for the liver at prescribed doses. It's a misnomer sometimes to think that you can't take Tylenol. We actually use Tylenol in patients who have hepatitis C cirrhosis, so they have like bad livers, but they can take Tylenol if we're looking to avoid injection reactions. Tylenol should definitely be avoided if you have significant alcohol use because it affects the enzymes in the liver. But we have no reason to believe in amyloid in general that you can't use Tylenol at prescribed doses, which is up to 1,000 milligrams 3 times a day. And it's overall going to be your safest first pain medicine compared to like anti-inflammatories, which sometimes have some hard effects.
Okay, great. Well, we do have a lot of questions yet that have not been answered, so I will be sending them out to our physicians folks so that they can answer them because we do have to let them go as usual. I went over time. And we really appreciate you. Now, we've got a presentation coming up from Paula. It's just a few minutes on financial aid and what to do if you have drugs that you wish to donate. We know there are various circumstances where someone, and physicians, you need to know this too. There are times when, when there are excess drugs that a patient might have, maybe you transferred them over from one drug to another, and they have some unused drugs in their medicine cabinet or whatever, and sadly there are some cases where a patient has died and the loved one is left with unused drugs. So there are legal ways to donate these drugs now that we have found out about, and we do want to share. So Paula's got a 5-minute presentation on financial aid that she's going to do, and then we'll wrap this up. But we want to thank you, Dr. Mitchell and Dr. Karam, for being here today, and we'll see you in October as well. And if you want to hang on and listen to Paula's presentation, it's well worth to listen to. So thank you again, and take care. And Paula, it's up to you, hon. Take it away.
All right. Thanks so much. It's been a pleasure.
Thank you. Right now, I'm going to go on ahead. Next slide, please. Okay, genetic testing is something that hasn't really been hit on much today, but for the families with hereditary TTR, if you have someone in your family that needs testing, know that these two programs are out there provided to you for free testing. There are certain qualifications that have to be met to qualify for this, but if you have a known TTR variant in your family, you should qualify for the free testing. But your doctors may or may not know about this. I know some people actually tell their doctors about it, so they are able to get these test kits sent out to them. But just know that these programs are out there and available. Next slide. Okay, another thing. All of the drug companies have support programs out there for patients on their drugs. I have a list of them here for the different drugs of the websites that you can go to. Now, these people are trained to help you. They can't give you medical advice, but they can help you on learning about the drugs, learning about side effects, that type thing. It varies what they can tell you, but call and talk to them. If you have not, get set up with their programs. If you are a low income person, you may be able to qualify for free drugs through the foundation sides of the pharmaceutical companies. Their employees can help direct you on that as well to see if you might qualify for free drugs. Just know that that is a possibility out there if you are lower income. And generally, I believe they're about 350% and lower of the federal poverty rate, which you'll see a chart later on in my presentation on how much you can make for each different percentage of the federal poverty rate and based on your household size. Next slide. Okay, good news now for everybody. Lately, it hasn't been great news, but right now there are actually 4 separate funds that are open from different charities for amyloidosis. That is unusual, to say the least. We usually may have 1 or 2 open during our webinars, but this time there are 4 that are open. One just opened day before yesterday, actually. I posted about that when they opened up. But you may be saying, well, we're already halfway through the year. I've met my out-of-pocket for the year. If you're on Medicare, because we now have the $2,000 out-of-pocket maximum, many of you may have already met that for the year. And you may be saying, well, I don't need financial assistance. I'm getting all of my prescriptions free for the rest of the year. Well, one thing you need to consider is that some of these funds will pay you for your premiums, your Medicare premiums, health insurance premiums. Varies according to the different plans. Some will only pay for Part B, as in boy, premiums, but that is something that you can apply for. Some of these programs also have travel assistance. So if you say fly to a center somewhere out of, you got to get on a plane and fly, or get on a train and go somewhere, or even drive. It will help pay for parking tolls, parking fees, your fuel, that type of thing, your hotels. So know that that is also out there, but they vary according to the different funds. The cardiomyopathy fund for the Healthwell Foundation, that one you have to be on Medicare to qualify for it. The amyloidosis fund that they have 2 separate funds. The amyloidosis fund, you do not have to be on Medicare yet to qualify for that. Both of those funds have to be at or below 500% of the poverty level. Now, one thing that you can do with the HealthWell Foundation funds, I don't know about the other funds. I'm telling you this because my husband has a HealthWell fund, and I know this from the paperwork we have gotten for him. But okay, again, I said we're halfway through the year right now. You know, you can apply right now, say, say your deductible's met. You can go ahead and apply now for premium assistance. Say you want to just get your premiums covered or your deductibles covered. You can apply now for that. And then at the beginning of 2026, when you have to meet that big $2,000 out-of-pocket deductible again, or the out-of-pocket max, you can, one time a year with HealthWell Foundation, you can change your fund to pay, it pays either or. It will either pay your Medicare premiums or it will pay for your prescriptions. So you can make that change once per year. So 6 months from now, or five months from now, when 2026 starts, say you get a grant this next week for your premiums. Okay, you want to change that in January to pick up that other $2,000 that you're going to have to pay out of pocket right now. It may be beneficial to you to do that, to change and change it over to where it now covers your prescription drugs for the next few months until you reach that $2,000. You have to look at it best how to work it for yourself. It may vary from person to person that, you may have a high deductible or high premium, and it may benefit you to have that one covered. So think about that when you're looking at these 4 programs that are open right now. Don't just grab one and say, oh, that one pays $8,000 a year, I'm going to go for that one. It may be actually that a different fund might benefit you more for your particular situation. So you want to talk to each one of these places and find out which one is a better fit for you. Okay. Nord, which is also here on the slide, I found out recently that they have their caregiver respite fund. You can apply as a caregiver for that fund, and if approved, they will pay for a certified nurse, a nurse practitioner, or just anybody that wants to come in and be a caregiver where you can have a little time off to yourself. They will, and you want to pay that person to be there. This caregiver fund will cover those costs for you. So if you would like to have a break like that, give Nord a call. You can go to their website and look under their assistance funds, and the caregiver, there's a separate caregiver fund listed. So you can click on that and find out more about it. But just know that that is out there available to you. Next slide, please. Okay, here's a few more that are open. We have the Patient Access Network. They have a fund that is $2,500 initially, but if once that is used up, it can be possibly expanded to $5,000 per year if they have the funding available. They have a $500 transportation grant that you can apply for, but you do have to be on Medicare in order to qualify for that assistance through them. Now, the assistance fund, their fund is also open. I cannot tell you much about their fund because when I called them asking for assistance, told them what I was doing, they didn't want to give me any information on it. So you'll have to call them, go on their website, and you can apply on the website, or call them and ask for more information on what their fund actually does cover and pay up to. I don't know the amount of the award that you may be given, but their fund does cover copays, travel, and premiums, and you do not have to be on Medicare to qualify for it. Patient Advocate Foundation, that is the only closed fund that we have right now. But if for some reason you wanted to apply for their grant for amyloid, you can sign up for a wait list with All of these funds have wait lists that you can sign up for. So if at some point throughout the year, or say next year, you look and the fund is closed, go ahead and sign up for the wait list, because they will then contact you when that fund becomes open again, where you can apply to get your coverage again, to possibly get another grant. Next slide. Okay, this is the chart that shows the federal poverty guidelines. And if you look in the far left-hand column, let's just say a household size of 2, a husband and wife. Each one of these funds has a different percentage. Some of them are 400% of the federal poverty rate. Some of them are 500%. But those are the amounts of money you can make living in the continental United States and still qualify for assistance through these grants. If you live in a large metropolitan area or an area with a higher cost of living, know that they do give an allowance for that. So if you say live in New York City and you make you're bringing in $106,000, go ahead and contact that organization and see how much of an allowance they give you for being in a higher cost of living area. You may still qualify, even though on the chart it looks like don't. There are allowances in certain areas for that, so please keep that in mind. Next slide. I had mentioned earlier about mailing lists. The Penn Foundation has what they call their Fund Finder. You can also go on the Fund Finder and join on with this, put down that it's amyloidosis that you want to keep track of, and they will list every amyloidosis fund that is out there, and it will show you whether it is open or not. This particular slide is for AL patients, basically. It was a screenshot I took years ago. But right here, the only one that is open with that green lock was the Leukemia and Lymphoma Society at that time. The red locks show that they are all closed. So, I sign up for all of these things. I signed up for the Fund Finder, and I also signed up for the individual mailing lists from each one of these organizations. You may get an email from one before you get another, and sometimes these funds will close very quickly. I'm shocked that they've been open as long as they have. I know they've been open for at least 2 weeks now, some of them, because they were open during our Jacksonville meeting 2 weeks ago. So these funds may be about to run out of money. So jump on them now if you are in need of funding or want to see if if you qualify for these. Go ahead and do it Monday. Don't wait around. They can close. Next slide. Okay, Muriel had mentioned the unused medication company that we have become aware of. It is called Serum. And if you go to this link right here, the website here, the link.serum.org/ASG, I have included that website and this card in the chat. There's links to both of them listed in there. But if you go to that, it will take you through their donation process. You can do this all online. They will send you a printing label, a shipping label, and you can send off any unopened drugs that you have. They cannot take an open bottle for obvious reasons, but if, say, it's a blister pack of pills, they can take that. If as long as each individual pill has not been opened up. So contact this company. You can contact me again if you forget the information. I have it saved. So this is a great way to be able to send your drugs to someone that can in turn have them donated to a person needing them. Now they use a separate company for the donated drugs. Serum is not allowed to distribute the drugs. There is a separate company called Good Pill that does that, but that has certain limitations that we're not going to go into today, but I can let you know about that further if you want to know about it. Just send me an email. But that, one other thing, all of our drugs, the drugs that are listed under each one of these foundations that give out these grants. There is a large list of different drugs that they cover. But say if you are low income again, and we've heard mentioned today, Farxiga, Jardiance, Eliquis, Xarelto, all of those newer drugs that are out there, they can be expensive. So if you for some reason don't qualify for a grant, or the grants are closed when you try to get a grant for amyloidosis, you can contact the drug company because they have copay assistance cards for people who are not yet on Medicare. You can get on a copay card and have a little to no copay each month for these drugs, or you may qualify again for free drug through the program with the pharmaceutical company. So always keep that in mind on any drug that you take. It doesn't have to be just your amyloid drug, that a lot of these pharmaceutical companies have assistance for their drugs out there. And you'll have to see, if you qualify financially to be able to get them from them. But just know that there is assistance out there. Don't think, my God, I can't afford any of these drugs, I just won't take them. There is assistance out there. Please, please reach out to us if you feel that you need assistance and haven't been able to find it. We'll try to help you locate a fund that you may be able to apply for and qualify with. So just know it's out there, folks. And that's about it. I thank you for your time.
Thank you so much, Paula. And Paula, some people were having problems accessing the three dots on the chat. I don't know if it's
Okay.
disabled or whatever. So if anyone out there is having any problem, with the chat, email Paula at amyloidosissupport.org. And also I'm going to ask Paula to give me all those links so that when I do send out copies of surveys and when this video is available, I will also send out a copy of that so that you can watch it again. So, and I'll include everything that Paula has mentioned as well. So and don't be shy, folks. Paula at amyloidosissupport.org. She gets lonely if she doesn't have emails to read. So please don't hesitate. And we do want to thank everyone for coming today. I want to thank our doctors. I want to thank Bob and Paula for the sensational job they do. I want to make sure that you fill out the survey. I'll send it out again for those of you that did not fill it out. And remember, today's recording won't be on YouTube or our website for a couple of weeks. So, but as soon as it is, we will share. I hold nothing back, and I hope to see a lot of you in person in October. It's filling up. It's exciting, and we can't wait for that. So have a great summer, and we'll all talk soon. Take care now.
Bye-bye, everybody.
Bye-bye.